Ladies and gentlemen, before I gavel this to a start, I think you already heard, please put your cell phones either off or preferably on airplane mode. You're certainly welcome to take pictures as long as you don't stand up or in any other way block other people. We have a large panel today. Members have flown in from all over the country to hear these people and to ask questions. So the only thing I ask is that please give them all the opportunity to do that. Applause, this is the one place applause is not appreciated. We have a 9% approval rating. You need not applaud for us. And with that, the committee will come to order. Without objection, the Chair is authorized to declare a recess of the committee at any time. The Oversight Committee exists to secure two fundamental principles. First, Americans have a right to know that the money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty on the Oversight and Government Reform Committee is to protect these rights. It is our solemn responsibility to hold government accountable to the taxpayers. Taxpayers want to be safe. Taxpayers want to know that our government is prepared. In this case, we leave no stone unturned in ensuring today that America is planning for tomorrow. Beginning in March 2014, in the West African nation of Guyana, the world first learned about yet another new outbreak of the Ebola virus. Due to poor detection, it is possible the outbreak started late last year. By August, Ebola had spread to Sierra Leone, Liberia, and Nigeria. According to the U.S. Center for Disease Control and Prevention, the 2014 Ebola epidemic is the largest in history, and sadly, the virus has claimed at least 4,000 lives to date. By the end of September, the CDC confirmed the diagnosis of the first travel-associated case of Ebola in the United States. The situation is rapidly developing and changing, and Americans are understandably worried about their government's response to the outbreak, and in particular, the steps we are taking to contain the spread of Ebola. With the high fatality rates as much as 70% and no FDA-approved vaccines or medicines, Ebola is a serious threat to public health around the world. An outbreak in an American city or any major city of the world could be very costly to contain and could have major economic impacts. Yesterday's news was a doctor in New York City tested positive for Ebola, and this is particularly distressing. There is certainly some good news to report on our effort to contain the outbreak. No new Ebola cases have been reported in Nigeria in 46 days. Over 40 people who came into contact with the Ebola patient, Thomas Eric Duncan, in Dallas, have now gone through the 21-day monitoring period without demonstrating any symptoms. And perhaps that means that our preventive systems of those in contact is good, even though, as we will see today, not perfect. We have the world's most advanced healthcare system, undeniably, in America. We spend the most money to have that system. And as long as our response is well coordinated and officials use common sense, there is an ability to contain this disease. But we are not out of the woods yet. Today we will examine efforts to coordinate Federal agencies tasked with responding to Ebola outbreak. This examination follows a series of statements and actions that have eroded public confidence in our response. An infected traveler from Liberia made it through the Department of Homeland Security screening and arrived at international travelers and into the Dallas-Fort Worth area. When the same individual exhibited clear signs of Ebola, symptoms of Ebola, a hospital turned him back into the community and offered an evolving account of how this happened. Without evidence, the director of the CDC declared that a nurse at this hospital who became infected with Ebola must have contracted it through, I quote, a breach of protocol. Medicine is not done over the telephone. It is not done over the television. Medicine is, in fact, the business of looking at a patient, evaluating a patient, measuring a patient, and questioning a patient, not, in fact, guessing how someone became a patient. A separate nurse who contracted Ebola at that hospital was cleared by the CDC to board a commercial airline flight, even though she reported having fever and contact with the patient, Mr. Duncan. The news of that medical doctor returning from Guyana has the news that a medical doctor returning from Guyana now has tested positive for Ebola has raised even more questions about procedures in treating patients and risk to Americans responding with great courage and generosity from here to the infected areas. We need to know why there have been breakdowns in it and if our system for responding to such serious crises is working properly. That was a line I was supposed to read. I think we all know that the system is not yet refined to where we could say it is working properly. How effective are our efforts at containing the disease in West Africa? Are the training and equipment that frontline healthcare workers and military personnel received in the past or will receive in the future adequate? Is an airport screening that went into effect 2 weeks ago reliable? Are government agencies doing everything they can do to foster the development of Ebola treatments? What threat does Ebola pose to international trade and Americans traveling abroad? When a situation like this arises, government is supposed to rely on prior planning and rapid, effective response that can identify mistakes quickly and correct them. Congress has recognized and considered the threat of an outbreak on a bipartisan basis. The bumbling we have seen comes despite concerted efforts by Congress to ensure protocols and funding were in place to avoid the very mistakes we have already seen. President Obama's appointment of Ron Klain to serve as the Ebola czar, sadly, in my opinion, shows the administration has on one hand recognized the missteps and on the other hand is not prepared to put a known leader in charge or, in fact, a medical professional in charge. That does not make it a political decision, but it makes it a decision in which we have to ask, and we will ask today, is the interagency coordination already in place and he is simply overseeing it, or in fact are we expecting Mr. Klain to put together interagency coordination, to show the leadership to make it happen, to sift through conflicting claims that science and medicine have already reached conclusions versus the reality that those conclusions, at least in several cases, have proven wrong. We did invite President's new czar, Mr. Klain, to testify, and we are very disappointed that he was not able to. But we understand he has just started, and we do not expect that that would be repeated if there is a follow-up hearing. Let me just say, in my role in this committee and others, I have traveled to the World Health Organization's headquarters. I have seen them saying to us as visitors that pandemics are in fact already planned for. And although they talk about the inevitability of a pandemic, we have also invested as Americans billions of dollars to in fact be prepared for them. Let me just say before anyone pulls the trigger on either a political or denouncing medicine, that in fact this is not a new problem. Nearly 100 years ago, in 1918, 1919, the influenza pandemic known as the Spanish flu killed more people than any other outbreak of disease in history. It claimed at least 20 million people thank you, around the world. In that pandemic, an American base, one that I was stationed at, Fort Riley, Kansas, proved to be the source of the first known outbreak. The flu spread fast around the base and other bases and eventually worldwide. Famously, the Big Red One is well aware that not only was the outbreak critical, but in fact, soldiers were put on ships and sent out from there, further not recognizing that in fact we were simply adding to the disease and the suffering. The Asian flu of 1957-58, which originated in the Far East, spread to the U.S. and caused at least 70,000 deaths. The Hong Kong flu of 1968-69 also spread the United States and caused an estimated 34,000 deaths. It would be a major mistake to underestimate what Ebola could do to populations around the world, and any further fumbles, bumbles, or missteps, or relying on postulates, certainties told to us by people who in fact cannot defend how that certainty came to be, and when it fails to be correct, how they could have been so wrong, can no longer be tolerated. I look forward to hearing from this panel of witnesses in an effort not to solve a problem, but to take the problem appropriately seriously, recognize that what we don't know could kill us. And with that, I recognize the Ranking Member for his opening statement.
Thank you very much, Mr. Chairman, and I thank you again and again for holding this hearing. I think this is the reason why we have an oversight committee, to address those problems that our nation, and in this case the world, face. Yesterday, Dr. Craig Spencer, a physician working for Doctors Without Borders, tested positive for Ebola. We're still getting additional details, but based on information from New York and Federal officials so far, it appears that healthcare authorities have come a long way in preparing for Ebola since Thomas Duncan first walked into a Texas hospital last month. New York had been preparing for this possibility for weeks, and about 5,000 healthcare workers were drilled on protocols and procedures just this past Wednesday. A special team with full protective gear transported Dr. Spencer to Bellevue Hospital, which is specifically designated to handle Ebola. They placed him directly into an isolation unit. They began treating him as soon as possible, and they started tracing his contacts immediately. As New York officials said last night, they had hoped they would not have to face an Ebola case, but they did. They were also realistic, and they worked diligently and professionally over the last month to prepare themselves for this day. There are many questions about this new case, but we cannot assume it will be the last. And I remind all of us, this is our watch. Of course, we must continue to be vigilant, and we need to continually reevaluate our protocols and training procedures to protect our healthcare workers, many of whom are here today. And to those healthcare workers, on behalf of a grateful Congress and a grateful nation, I thank you for what you do every day. I want to express our thanks to Nina Pham and to Amber Vinson, the two nurses from Texas who contracted Ebola when they treated Mr. Duncan. By now, we've all seen their pictures. Two brave young women who risked their lives to simply do their jobs and to feed their souls. Just like nurses across this country, every single day, 24/7, 365 days a year. I understand that Ms. Pham's condition has been upgraded and Ms. Vinson has now been cleared of the virus. We thank them for their bravery and their commitment. This new case in New York should also demonstrate that we can no longer ignore the crisis in West Africa. We can no longer ignore it. Nearly 10,000 people have died from this disease or are battling it with it as we speak, many in the most gruesome conditions imaginable. I firmly believe we have a fundamental moral and humanitarian obligation to address the crisis in Africa. We are the richest nation in the world, and we have the resources and expertise to make the biggest difference. However, for those who may not agree that we have a moral obligation to help, they must understand that addressing the Ebola crisis in Africa is also in our self-interest as a nation. Public health experts warn that to protect Americans here at home, we need to address this outbreak at its source in Africa. The longer the outbreak continues, the more likely it will spread to the rest of the world, including more cases right here in the United States of America. And if we do not take strong action now, it will cost much, much more in the long run. The encouraging news is that healthcare experts know how to fight this disease. They know how to do that. This week, the World Health Organization declared Nigeria and Senegal free of Ebola. This is a tremendous accomplishment that was achieved through a combination of early diagnosis, contact tracing, infection control, and safe burial. But we still face grave challenges in Sierra Leone, Guinea, and Liberia, where the public health infrastructure is deficient and new cases are increasing at an alarming rate. Last month, the United Nations Security Council unanimously adopted a resolution declaring the Ebola outbreak, and I quote, a threat to international peace and security, end of quote. The UN established a mission for Ebola emergency response. They set forth more than a dozen mission-critical actions, and they provided a 6-month budget request for $988 million. However, they are hundreds of millions of dollars short. They desperately need funding for treatment beds, training for healthcare workers, and supplies to prevent infection. They need resources for things as basic as food and vehicles and fuel. As the head of the United Nations mission warned the Security Council just last week, and I quote, "We either stop Ebola now or we face an entirely unprecedented situation for which we do not have a plan," end of quote. There have already been several congressional hearings on how to prepare ourselves here in the United States. So today I intend to ask our witnesses what they believe in their expert views are the most significant, concrete, and constructive steps our nation can take to address this outbreak at its source. I'm particularly grateful to Mr. TORBAY from the International Medical Corps for agreeing to be here today to provide his on-the-ground assessment of what his group and others on the front lines need to stop the spread of Ebola. Mr. TORBAY, I know you must feel great empathy for Dr. Spencer, who tested positive yesterday. I have asked my staff to place your testimony on our website. It's some of the best testimony explaining what is going on in Africa, things that work, and I think the public should have an opportunity to read all 10 pages. Dr. Spencer was one of your compatriots battling Ebola in West Africa, and I'm sure his situation is one that all of your healthcare workers must fear on a daily basis. But the truth is that Dr. Spencer and your group and many others are doing one of the only things that will truly ensure the world will be free of Ebola. We need to support you as much as we urgently can, and we must do it forcefully. And we have to convince the rest of the world to do the same. Again, I say this is our watch. And to my fellow committee members and the members of this great Congress, it is not a time for us to move to common ground. We have no choice but to move to higher ground. And so, with that, Mr. Chairman, I look forward to the testimony today, and with that, I yield back.
I thank the gentleman. All members will have 7 days to submit opening statements for the record. And with that, we go to our panel of witnesses. The Honorable Michael Lumpkin is the Assistant Secretary of Defense for Special Operations and Low-Intensity Conflict at the United States Department of Defense. Major General James LARIVIERE, or close enough, is the Deputy Director of Political Military Affairs in Africa at the United States Department of Defense. The Honorable John Ross, sorry, I just got off a flight, I apologize. The Honorable John Roth is the Inspector General for the United States Department of Homeland Security. The Honorable Nicole LURIE is the Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. Ms. Deborah Berger is the Co-President of the National Nurses United, and Mr. Rabin TORBAY is the Senior Vice President of International Operations at the International Medical Corps. Ladies and gentlemen, pursuant to the rules of the committee, would you please all rise, raise your right hands, and take the oath. Do you solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Please be seated. Let the record reflect that all witnesses answered in the affirmative. As you all can see, we have a large panel, and I know from the dais there will be many questions. So I'd ask that you realize that your entire opening statements will be in the record and that you limit your oral testimony in your opening to 5 minutes. With that, Mr. Lumpkin.
Chairman Issa, Ranking Member Cummings, and distinguished members of the committee, thank you for the opportunity to be here this morning regarding the Department of Defense's role in the United States' comprehensive Ebola response effort, which are a national security priority in response to a global threat. Due to the U.S. military's unique capabilities, the Department has been called upon to provide interim solutions that will allow other departments and agencies the time necessary to expand and deploy their own capabilities. U.S. military efforts may also galvanize a more robust and coordinated international effort, which is essential to contain this threat and to reduce human suffering. Before addressing the specific elements of DoD's Ebola response efforts, I would like to share my observations of the evolving crisis and our increasing response. After visiting Liberia, which I returned from several weeks ago, I was left with a number of overarching impressions that are shaping the Department's role supporting USAID. First, our government has deployed a top-notch team experienced in dealing with disasters and humanitarian assistance. Second, the Liberian government is doing what it can with its very limited resources. Third, the international response is increasing regionally due to our government's response efforts. Fourth, I traveled to the region thinking we faced a healthcare crisis with a logistics challenge. In reality, what I found was that we face a logistics crisis focused on a healthcare challenge. Fifth, speed and scaled response matter. Incremental responses will be outpaced by a rapidly growing epidemic. Finally, the Ebola epidemic we face is truly a national security issue. Absent our government's coordinated response in West Africa, the virus's increasing spread brings the risk of more cases here in the United States. And now I'd like to turn to DoD's role of our overall whole-of-government response in West Africa. In mid-September, President Obama ordered the Department to undertake military operations in West Africa in direct support of USAID. Secretary Hagel directed that U.S. military forces undertake a twofold mission. First, support USAID in the overall U.S. government efforts, and second, respond to Department of State requests for security or evacuation assistance if required. Direct patient care of Ebola-exposed patients in West Africa is not part of DoD's mission. Secretary Hagel approved unique military capabilities falling under 4 lines of effort: command and control, logistics support, engineering support, and training. In the last 6 weeks, DoD has undertaken a number of synchronized activities in support of these lines of effort, to include designating a named operation, Operation United Assistance, establishing an intermediate staging base in Dakar, Senegal, providing strategic and tactical airlift, constructing a 25-bed hospital in Monrovia, constructing up to 17 Ebola treatment units, also known as ETUs, in Liberia, and preparing to train local and third-country healthcare support personnel, enabling them to serve as the first responders in these Ebola treatment units throughout Liberia. I would like to reiterate that the U.S. military personnel will not provide direct care to Ebola patients in West Africa. In addition to the activities of Operation United Assistance, the Department continues 2 enduring programs in the region. Operation Onward Liberty partners with Armed Forces of Liberia to improve their professionalism and capabilities, and we are expanding the regional efforts of the Department's Cooperative Biological Enhancement Program to provide robust enhancements to biosafety, biosecurity, and biosurveillance systems in West Africa. In all these circumstances, the protection of our personnel and the prevention of any additional transmission of the disease remain paramount planning factors. There is no higher operational priority than protecting our Department of Defense personnel. In conclusion, we have a comprehensive U.S. government response and increasingly a coordinated international response. The Department of Defense's interim measures are an essential element of the U.S. response to lay the necessary groundwork for the international community to mobilize its response capabilities. Now it is the time to devote appropriate U.S. resources necessary to contain the threat and to establish the processes for better future responses. With that, I would like to introduce my colleague from the Joint Staff, Major General LARIVIERE, and we look ready to answer your questions and appreciate the opportunity to be here.
Thank you. And I understand, General, you do not have a separate opening statement.
No, sir, I do not, but I stand ready to answer any questions you might have.
Thank you. Mr. Roth.
Good morning, Chairman Issa, Ranking Member Cummings, and members of the committee. Thank you for inviting me to testify about DHS's management of pandemic supplies. DHS must have the ability to continue its operations in the event of a pandemic. In 2006, Congress appropriated $47 million in supplemental funding to DHS for them to plan, train, and prepare for potential pandemic. We recently conducted an audit of those efforts, focusing on the Department's preparations to continue operations and achieving its mission should a pandemic occur. The report of our audit is attached to my written testimony that I have submitted to this committee. In short, our audit concluded that DHS mismanaged their program in 3 ways. First, we found that DHS did not adequately conduct a needs assessment before purchasing protective equipment and antiviral drugs. As a result, we could not determine the basis for DHS's decisions regarding how much or what types of pandemic supplies to purchase, store, or distribute. As a result, DHS may have too much of some equipment and too little of others. For example, we found that DHS has a stockpile of about 350,000 white coverall suits and 16 million surgical masks, but hasn't been able to demonstrate how either fits into their pandemic preparedness plans. It has a significant quantity of antiviral drugs, but again, without a full understanding of the Department's needs in the event of a pandemic, we have no assurance that the quantity of drugs will be appropriate. Second, DHS purchased much of the equipment and drugs without thinking through how these supplies would need to be replaced. The material DHS has purchased has a finite shelf life. For example, TSA's stock of pandemic protective equipment includes about 200,000 respirators that are beyond the 5-year usability date guaranteed by the manufacturer. In fact, the Department believes that their entire stockpile of personal protective equipment will not be usable after 2015. Likewise, the antiviral drugs DHS purchased are nearing the end of their effective life. DHS is attempting to extend that shelf life of these drugs through an FDA testing program, but the results of that are not guaranteed. Third, DHS did not manage its inventory of drugs or equipment. As a result, DHS did not readily know how much protective equipment and drugs it had on hand or where it was being stored. Drugs and equipment have gone missing, and conversely, our audit has found drugs in the DHS inventory that the Department thought had been destroyed. We visited multiple sites and found drugs that were not being stored in a temperature-controlled environment. Because DHS cannot be assured that they were properly stored, they are in the process of recalling a significant quantity of them because they may not be safe or effective. We made 11 separate recommendations. DHS has concurred with all of them. One of those recommendations has been fully implemented. The Department is taking action to implement the remaining 10 recommendations. We will continue to keep this committee informed about the Department's progress. Mr. Chairman, that concludes my prepared statement. I welcome any questions.
Dr. LURIE.
And other distinguished members of the committee. I'm Dr. Nicole LURIE, the Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. I'm also a primary care doctor. I appreciate the opportunity to talk with you today about the steps that HHS and other agencies have taken since the Ebola outbreak began in West Africa. We are working 24/7 to control the epidemic there and to ensure that we are prepared to prevent and curtail the spread of disease here at home. Thanks to the foresight of the Congress, the leadership of this and prior administrations, the dedicated work of HHS and the interagency, whole-of-government approach we are taking, we are better positioned than ever before to respond to Ebola, as well as a range of other threats that may affect this country. I serve as the Assistant Secretary. I serve as the Principal Advisor to the Secretary on all matters related to public health and medical preparedness and response for emergencies. Since my confirmation in 2009, we've worked hard to ensure that we have the tools necessary to prepare for and respond to any disaster with public health consequences. I have led the modernization of the medical countermeasure enterprise, created new opportunities for coordination among state and local public health and healthcare systems, and strengthened our ability to make better decisions before, during, and after an emergency. Our all-hazards approach allows us to be flexible and nimble in response to known and unknown threats. As you know, 4 cases of Ebola have been detected in the United States. Our hearts go out to the family of Mr. Duncan, the nurses who have been infected, as well as the physician in New York. We're pleased that the nurses are doing so well and wish them and the physician a speedy recovery. We are extremely serious in our focus on protecting America's health security. The best way to do that is to end the Ebola epidemic in West Africa. At the same time, we're expediting the development of medical countermeasures and preparing our systems to deal with any potential cases in this country. So, not long after this epidemic began, I convened the federal medical countermeasure stakeholders to see what could be accomplished as quickly as possible. Thanks to past investments, we've leveraged U.S. government-wide assets to urgently speed the development and testing of vaccines and therapeutics for Ebola. These advances are allowing us to create Ebola countermeasures in record time so that we'll have products to use as soon as we have the necessary proof of efficacy. Our strategic investments in the countermeasure infrastructure, including our Centers for Innovation in Advanced Development and Manufacturing established in 2012, and newly established fill-finish manufacturing network, will be used to get Ebola vaccines and therapeutics into vials for use. We're also leveraging our strong, ongoing relationships with industry and public-private sector partners to scale up vaccine manufacturing. In addition, our public health and healthcare systems must be prepared to deliver safe care at a moment's notice. Investments in the hospital preparedness program and the Public Health Emergency Preparedness Program have meant that healthcare systems and state and local public health departments are prepared to respond to public health emergencies. Since the epidemic began, we've been using these programs to educate healthcare system stakeholders and ensure surveillance and laboratory capacities were in place. We've launched a very aggressive national outreach and education program to promote the safe and effective detection, isolation, treatment of Ebola patients. The system we now have in place is based on changes and lessons learned from each emergency, including those I've confronted as the Assistant Secretary. Based on the first U.S. cases, HHS has already made adjustments to minimize the spread of Ebola. These include tightened guidance for the use of personal protective equipment, an expanded aggressive national education campaign for healthcare workers, and screening and active monitoring of passengers entering the United States, now funneled through 5 airports. We've been working collaboratively with our interagency partners, including on transport of contaminated waste with the Department of Transportation, medical evacuation with the Department of State, deployment of military personnel with the Department of Defense, and worker and workplace safety with OSHA and NIOSH. Mr. Chairman and members of the committee, I understand why you and your constituents are concerned. We take domestic preparedness very seriously. Our top priority is protecting the health of Americans. I can assure you that my team, the Department, and our partners have been working and continue to work long hours to prepare our nation for threats like this. With lessons learned from this new challenge, we're making efficient use of the investments provided, and we have made tangible, meaningful progress since you first created this office in 2006. As a result, HHS has been able to provide crucial health and medical support to our states and communities. I thank you again for this opportunity to address these issues and welcome your questions.
Ms. Berger.
Members of the committee, I am Deborah Berger, a registered nurse.
Could you pull the mic just slightly closer? Thank you.
Thank you. And co-president of the National Nurses United, representing 190,000 members in the largest organization of nurses in the United States. The Ebola pandemic and the exposure of healthcare workers to Ebola in Texas and the real threat that it could occur elsewhere in the U.S. represent a clear and present danger to public health. Every RN who works in a healthcare facility could be Nina Pham or Amber Vinson, both of whom contracted Ebola while treating Thomas Eric Duncan at Texas Presbyterian Hospital in Dallas. 1 patient diagnosed and dead in this country, 2 nurses infected so far. In our survey of over 3,000 nurses from over 1,000 hospitals in every state, D.C. and the Virgin Islands reveals 85% of the nurses say they are not adequately trained and the level of preparation for Ebola in our facilities is insufficient. 68% of RNs still say their hospital has not communicated any policy for admission of a potential Ebola patient. 84% still say their hospitals have not provided Ebola education with the opportunity to interact and ask questions. 44% say their hospitals lack insufficient supplies of eye protection now. 46% say there are insufficient supplies of fluid-resistant impermeable gowns in their hospital. 41% say their hospitals do not have plans to equip isolation rooms. Initially, the nurses who interacted with Mr. Duncan wore non-impermeable gowns, 3 pairs of gloves with no taping around the wrists, surgical masks with the option of N95s, and face shields, leaving their necks exposed. 2 of them became infected. This is what happens when guidelines are inefficient and voluntary. The new CDC guideline that protective equipment leave no skin exposed is a direct testament to the courage of Dallas whistleblower Brianna Aguirre, who first spoke to us. We have called on President Obama to invoke his executive authority and urged Congress legislatively to mandate uniform, optimal national standards. These include full-body hazmat suits that meet the ASTM F1670 standard for blood penetration and the ASTM F1671 standard for viral penetration, which leaves no skin exposed or unprotected. NIOSH approved air-powered purifying respirators with an assigned protection factor of at least 50 or higher standard as appropriate. At least 2 direct care RNs for each Ebola patient and no additional patient care assignment. Continuous on-site interactive hands-on teaching with the RNs and updates responsive to the changing nature of the disease. The precautionary principle must be utilized when developing public health policy designed to protect patients, the public, nurses, and all healthcare workers who may be exposed to potentially infectious patients. Lest we forget, the risk of exposure to the population at large starts with the frontline caregivers. It does not end there. As we've seen with school closures in Ohio and Texas and the quarantining of airline passengers, improper protection and inadequate protocols in hospitals can lead to public exposure. The response to Ebola from U.S. hospitals and governmental agencies has been dangerously inconsistent and inadequate. The lack of mandates and shifting guidelines from agencies and reliance on voluntary compliance has left caregivers uncertain, severely unprepared, and vulnerable to infection. Our experience with U.S. hospitals is they will not act on their own to secure the highest standards of protection without a specific directive from our federal authorities by an act of Congress or potential presidential executive order. The new CDC guidelines represent progress with improved standards for training, as we have been demanding for months. The CDC guidelines are still unclear on the most effective protective equipment, specifically allowing hospitals to select protective equipment based on availability and other factors. We are your first line of defense. No nation would ever contemplate sending soldiers into the battlefield without armor and weapons. Give us the tools we need. All we ask from President Obama and Congress is not one more infected nurse. Thank you.
Thank you. Mr. Torbay.
Chairman Issa, Ranking Member Cummings, and distinguished members of the committee, on behalf of International Medical Corps, one of the few agencies in the world to be treating Ebola patients, I would like to thank you for inviting me to testify today and for your leadership in convening this critically important hearing. We would also like to express our appreciation to the U.S. government for their pivotal action and generous support for the response. Our response to the Ebola outbreak has been robust. By the end of November, I anticipate we will have a total of about 800 staff in Liberia and Sierra Leone. Approximately 70 of these will be expatriates. International Medical Corps has been operational in West Africa since 1999. Our Ebola response started in late June with community education and sensitization in Sierra Leone. In late July, and after we realized the epidemic has reached out of control levels, we deployed our emergency response teams to both Sierra Leone and Liberia and decided to get involved in treatment of Ebola cases. When our emergency teams arrived in Liberia in August, what we found on the ground confirmed that urgent action was required. In a few short months, fallout from the Ebola outbreak had brought the country's already fragile healthcare system to the brink of collapse. Many were dying. Most were afraid. Previously busy hospitals and clinics were empty, with both staff and potential patients too frightened to go there for the fear of being infected with the virus. Rather risk infection, mothers shunned life-saving vaccination for their children, and if their child became ill, even seriously ill, all too many believed the safer option was not to seek treatment at all. With funding from USAID, we opened up our first 70-bed Ebola treatment unit in Bong County in Liberia, and we admitted our first patients on September 15th. Currently, we have 53 beds occupied and staffed by a team of 17 expatriate and 161 Liberian nationals. To date, this ETU remains one of just 2 in Liberia operating outside of Monrovia. Within the next 6 weeks, We expect to open 3 additional Ebola treatment units, 1 in Liberia, in Margibi County, and 2 in Sierra Leone's northern province, specifically in Lunsar and Makeni. Within the next 3 weeks, we expect to open a training center in Bong County to train other NGO staff on case management protocols. In this center, which will be adjacent to our Ebola treatment unit, we will offer a fast-paced 7 to 12-day training for those that will be involved in the treatment of Ebola patients. We will open a similar center in Sierra Leone in the near future as well. Such hands-on training is the key to protecting healthcare workers who must operate in an environment where all know the Ebola virus is present. Strong guidelines and regulations are important, but they must be combined with hands-on training to be truly effective. Mr. Chairman, I would like to briefly share some of what we know works. This will help highlight several key areas to focus as well as what is needed going forward. First and foremost, we need to contain the disease at its source. For that to happen, we have learned that several factors need to be in place. This includes having operational Ebola treatment units that are staffed by well-trained health professionals, a robust referral system between community care centers and Ebola treatment units, as well as between Ebola treatment units themselves to take advantage of available bed capacity in certain areas. Limiting the spread of the virus in the community is essential to containment plan. Therefore, a focus on community sensitization, including education, awareness, and outreach, are critical. Finally, contact tracing and burial teams are critical to limit transmission. I would like to conclude by offering some recommendations to the committee for consideration. More detailed recommendations can be found in our written testimony. First, one of the most critical lessons learned from this response has been the importance of having the human resources ready and prepared to address an outbreak of infectious disease. Cadres of healthcare workers need to be well-trained and supported to staff the treatment units and care centers in the affected countries, as well as to prepare other countries in the region for any potential future outbreaks. Second, ensure availability of appropriate personal protective equipment. Third, ensure clear protocols for evacuating healthcare workers. This is essential for our recruitment, training, and retaining of health staff in Liberia and Sierra Leone. Fourth, open airspace to and from the Ebola-affected countries must be maintained. The growing restrictions on travel to and from West Africa will only isolate the affected countries further, compromise the supply chain, and inhibit efforts to recruit qualified staff. These factors will further enable the severe outbreak to continue. Fifth, we need to accelerate the support the production and vaccines and innovative technologies. Finally, in developing and implementing recovery efforts and a long-term strategy, we must focus on building stronger healthcare systems in the region. Mr. Chairman, there is no doubt that we will stop this outbreak, end the death, and if done correctly, build the tools to prevent another outbreak of such proportions. International Medical Corps looks forward to working with you to make this happen. Once again, thank you, Mr. Chairman and Ranking Member Cummings, for allowing me to present this testimony. I would be glad to answer any questions the committee might have.
Thank you. I'd like to thank all our witnesses. I'm going to withhold my questioning at this time and let Mr. Turner go first. The gentleman from Ohio is recognized for 5 minutes.
Mr. Chairman, I greatly appreciate that. I'm under a time constraint, having to return back to my district, and I greatly appreciate the Chairman doing that. Tuesday, I had the opportunity to talk to Secretary Hagel about the Ebola mission, and I believe that he takes this very serious, and he's very concerned both about the effects on our men and women in uniform and also on the effects of protecting the American public. I am very concerned about the protocols of protecting the American public, and since I only get one question, my question is going to be about that, although I too am very concerned, as all the American public is, about the protection of our men and women in uniform. I'm very skeptical of the DoD protocols, and I think the American public is very skeptical. We have basically 2 threats: 1, Ebola coming here, or 2, individuals who have been exposed to Ebola falling ill to Ebola. We've had 4 cases. 2 came here. 2 were a result of people being exposed to Ebola here and then falling ill. 3 were healthcare providers. Now, the American public is very concerned that individuals who have been exposed to the Ebola virus have had significant public access after being exposed. This is during a period while they were falling ill to Ebola. Now, on October 10th, Ebola came to visit Ohio. Amber Vinson traveled from Dallas, Texas to Cleveland. While she was in Cleveland, she visited local businesses. Of course, she flew on a flight there. Almost 300 people had contact with her while she was falling ill to Ebola. Fortunately, Ohio doesn't have a report at this time of a case of Ebola, but on October 20th, the entire Ohio congressional delegation, on a bipartisan basis, sent a letter to the CDC challenging their protocols with respect to people who have been known to have been exposed to Ebola. Now, we all know the stories: trying on wedding dresses, flying, going on a cruise, bowling, riding the subway. Although some of these issues are personal responsibility, they do go to the issue of protocols, and if you look at the October 10th Department of Defense guidelines, in paragraph 4, it says that a commander has authority, which means they may, they don't have to, quarantine someone up to 10 days if they're concerned about an individual who's been exposed. Now, we all know that the doctor in New York fell ill apparently after 11 days. And then it goes on to say that no known exposure, and that doesn't mean they weren't exposed, it means no known exposure, that there's a 21-day monitoring period, but it suggests that the individuals return to routine daily activities. Well, those routine daily activities would include going on cruises, flying, wearing wedding dresses, bowling, and riding the subway. So I think I'm very concerned, as the American public is the multiplier effect of the contacts that could occur in the public. And as we're learning, as we've looked at in light of what has happened, I believe that both the CDC rules and perhaps the DOD guidance should be revised. General, in light of what we now know and what we're seeing and our concerns of the multiplier effect, again, of 3 healthcare providers who had significant public contact while falling ill to the Ebola virus, do you believe that this October 10th DOD guidance should be revised? And Mr. Lumpkin, I'd like your answer to.
I think the first thing I'd like to say is to make sure, as I mentioned in my opening statement, is that we at DOD in West Africa are not doing direct patient care. So our operations and in support of USAID are focused on those lines of effort of the command and control, the logistics.
But Mr. Lumpkin, as you know, that does not mean that no one is going to be exposed to the virus. I mean, I understand what you're saying about the distinction between healthcare providers and non-healthcare providers, but the gentleman who flew here first, patient 1 in the United States, was not a healthcare provider either.
No, very true. But I want to make sure you understand is that because we're not, we have different categories of risk, and I'd like to turn it over to my joint staff colleague here to explain the risk categories and the mitigation strategies with each one of them.
Mr. Turner, thank you for the excuse me, thank you for the question. The protocols that we've put in place, we think, exceed the CDC standard. As you mentioned, we will be testing personnel twice a day while they are deployed, to take their temperature and to ensure that that if they were exposed and they did become infected, we could isolate them effectively. The 0 to 10 day timeline that you discussed is the timeline that will take place in country. Commanders will have the authority to remove their personnel.
But General, as we already know from the doctor in New York, he indicated, if the news reports are correct, that his symptoms occurred at 11 days. So
yes,
isn't your 10 days too short?
Yes, sir. Well, the 10 days were in country. The 21 days can't start until they're actually out of the affected area. So the 21-day monitoring period will take place.
Which means they could be traveling on day 11 and no longer isolated.
They could be traveling on day 11, but they will.
Which would result in additional exposure.
No, sir. We will try to limit their exposure prior to their departure, but the 21-day timeline won't start until they're back in the United States.
Well, my time is out, but I want to indicate I am highly skeptical. The American public is worried. I believe these need to be revised. The Ohio delegation sent to CDC, they believe theirs need to be revised. The American public is concerned that people who are exposed are having too much contact with the American public and raising the risk to the United States citizens. Thank you, Mr. Chairman. I appreciate it.
Thank you. And General, I just want to make sure, as the ranking member, I just want to make sure that you're clear in what you're saying and what Mr. Turner was asking. If someone, like the doctor in New York that just tested positive, is in fact held for 10 days, leaves on a commercial airplane, one of your gunny sergeants leaves on an airplane, arrives in New York, and on the 11th or 12th day goes positive, your 10 days will have done nothing, and you won't get that opportunity to have them outside. In other words, the quarantine of 21 days after you get back doesn't matter. And I think that's what Mr. Turner was very much asking, is the example he gave of the doctor from just yesterday tells I think all of us that 10 days isn't long enough if that person then travels on a commercial airplane where they then can infect the passengers on the airplane. Is that your question, Mr. Turner?
Correct, Mr. Chairman.
Thank you. Do you have any further clarification?
Perhaps I'm not being clear. The 10 days is to attempt to limit their possibility for exposure while they are in country in Liberia. They will then be screened for temperature and possible exposure prior to getting on a government contract or U.S. military aircraft to be returned to their unit back in the United States. Once they have flown back to their unit in the United States, they will be given a 21-day monitoring period where they will be required to come into the unit twice a day for medical checks by U.S. military medical personnel at their unit, where they will have their temperature taken and looked in the eye by a medical professional to see how they are doing. That will take place for 21 days back in the rear area to ensure that they do not become infected. They will never be more than 12 hours from possibly spiking a fever. If they did exhibit symptoms and spike a fever once they were back in the United States during one of those medical checks, they would immediately be taken to a treatment facility and begin the isolation process.
Mr. Cummings.
Yes, Mr. Torbay, I want you to remember what was just stated, and I want you to comment on that in a minute. I'm really curious as to what you deal with this every day, so what you think of it. But I want to go to some other things first. I know your organization is incredibly busy, but your input is very crucial. In addition to your very detailed written statement, you provided some pictures, and I'm hoping you can explain what we're seeing. First, I believe this picture is an Ebola treatment center. Can you briefly describe what we're seeing here, and where is that?
Absolutely. This is in Bong County in our Ebola treatment unit. This is the isolation unit. What you see, the two health workers in yellow suits with a hood and a mask are actually inside the restricted areas. Nobody is allowed to go in there without full personal protection equipment and training. And outside, they're taking notes. There's a supervisor to make sure that proper protocols are taking place as they're entering the Ebola treatment unit.
And in your testimony, you said you need about 840 of these suits every week. You also said this, and I quote, "The current demand far exceeds the supply. There are currently 2 main manufacturers for our acceptable overalls, and they are producing at full capacity." You go on to say, "We estimate that at the current stage, they will meet around 35% of the demand." Is that right?
That's correct.
And so what can we do to help provide more protective gear?
Absolutely. First of all, I'd like to clarify that it's 840 PPEs for a 60-bed hospital. That's for one Ebola treatment unit. It's not for the entire operation. What we need to do is encourage those manufacturers to increase the supply line and make sure that anybody who has the capacity or has some of those PPEs in stock to release them, because a lot of them are in stock in areas that are not actually endemic, and they need to be released for those that are treating patients.
Now, going back, let me go to another picture. Mr. Torbay, in this picture, there's a little truck in the background, and it has some kind of tarpaulin or flatboard bed. Can you tell us what the truck is used for?
This is a makeshift ambulance. There's a lack of ambulances in Liberia, so we took a flatbed truck, we put a mattress in it, and we cover it with a tarp, and this is what we take to get patients from the community to the Ebola treatment unit.
Well, in your written statement, you said, and I quote, "Put simply, we need 3 things: people, commodities, and money." By commodities, I mean everything from PPEs to disinfectant to vehicles for transportation, mattresses, and bed and clothing. End of quote. So is this what you're talking about in additional vehicles to transport patients? Is that what you're talking about?
Absolutely. To transport patients, additional vehicles for burial teams, ambulances that could go out to the community care centers, and transfer patients to the Ebola treatment unit for treatment.
Now, let me go to the next picture. This is not a picture you provided, but one from a hospital in Sierra Leone. There are people on the floor. There's fluid everywhere, and there's a team of people in full protective suits and appear to be removing a dead body. Can you please explain why it is so important to have proper burial procedures?
Absolutely. The viral load in a dead body is at its highest. This is when it's most contagious. So it's extremely important to have proper burial procedures. The way we go about it, when a person succumbs to the disease, we spray them with disinfectant, chlorinated water. We put them in a body bag, we spray them again, we spray the body bag again. We put them in a second body bag, we spray the body bag again, and a third body bag, and we spray them before we transfer them to the burial ground. So it's extremely important that proper burial procedures are followed all the time.
And would more resources help with that process that you just described?
Absolutely, sir.
And how so?
We need more burial teams. The burial teams on the ground in the 3 countries are not enough. They possibly contribute probably a third of the need. And we need body bags, we need training for the burial teams, as well as vehicles for transportation of dead bodies.
Mr. Chairman, with the committee's indulgence, I'd like to play a very short video clip showing how the final stage of this process, the burials, is currently being handled. Clip, please.
I'm working at a grave digger. I'm not a doctor, neither a nurse. My own skill, I'm a laborer, did it higher. Instead of me spending days for nothing, I decided joining the process to fight against Ebola. The work here is not easy, though. Our brothers and sisters, they are all dying day and night, every day. They brought a baby here when the baby died. 4 days old baby, so that they can bury the baby close by her mother.
Thank you, Mr. Chairman. Mr. Torbay, right now there are a lot of people watching this hearing, and many of them do not know the extent of the crisis in West Africa. They do not know the urgency of the need. You have a microphone in front of you, and you have an opportunity to reach millions of people this morning. If there is one thing you want to tell the American people, what would that be?
Thank you, Mr. Cummings, for giving me this opportunity. We need to deal with the Ebola virus at its source in West Africa. Steps can be taken in order to deal with this. We need to immediately increase treatment capacity by deploying and training proper health personnel. We need commodities, as we discussed, PPEs, ambulances. We need financial resources. We need further containment at the community level as well. It's not just about treatment, we need to contain it at the community level. This is a global issue. It's not just a West Africa issue. We all need to work together as one team to tackle this deadly disease and put an end to this outbreak. Once we do so, we need to continue the investment in rebuilding the healthcare system in West Africa, as well as preparedness in other countries. We need to make sure that this outbreak doesn't reoccur. The U.S. has and is playing a pivotal role. I am proud to say that the U.S. has led the way and continues to answer the call, and other countries are following the lead of the U.S.
Just one last thing. Mr. Turner asked I thought a great question, and the Chairman tried to get some clarification of our military folk. What was your reaction to, you deal with this disease. We've got healthcare workers in the back of you and the American people looking on. I mean, what do you feel that that's an appropriate way to address this? And should the American people be concerned? I mean, we've got people going over to Africa to try to help out.
I would like to clarify one thing. If there are no symptoms, there's no transmission. That's the first thing. Unless the patient develops symptoms, the patient cannot transmit the Ebola virus. So monitoring temperature is critical, because as long as the patient is asymptomatic, there's no risk of transmitting the disease. We follow slightly different protocol, but it's very much in line with what the General said, as well as with the CDC. There's no risk, which means somebody who hasn't been exposed to the Ebola virus. He hasn't been in contact with somebody knowingly infected with Ebola. We bring them on a commercial airline. They monitor their temperature for 21 days. Twice a day, we contact them to make sure it happens. There's low risk or some risk, and those people, we do not allow them to actually travel on commercial airlines. We ask them to stay out of the risk area, even in West Africa, but out of the risk area for 21 days to make sure that actually they have no symptoms before we allow them back. And there's high risk. Those are people that have knowingly been exposed to the virus. Those will be quarantined and monitored, and the minute they develop symptoms, they will be tested for Ebola and admitted.
Thank you, Mr. Chairman.
Thank you. And I want to follow up on the ranking member at that point. So if I heard you correctly, the fact is the 10-day waiting period has absolutely no value. That, in fact, the only real question, the only real way to ensure that someone is not contagious or not going to become contagious is for them to be outside the risk area for 21 days, not exposed to other people who exhibit symptoms for 21 days. Is that correct?
I think where the 10 days comes from is that the majority of symptoms appear within 7 to 10 days after.
Or 11 in the case of the gentleman in New York.
That's absolutely. I said the majority, there are exceptions. The incubation period is 2 to 21 days. That's why it is important to wait for 21 days after the last known exposure to the virus.
Again, known exposure, that's correct. Now, General, you're going to be operating some 7 labs. You said you're not doing medicine, but anyone who works in those labs, takes materials out of those labs, has secondary exposure to, if you will, liquids and so on, in fact, is in a direct risk, aren't they? The testing labs, because we've already had that in Dallas, is in fact a point of transmission. It's not just the individual, but in fact the materials that come out of that individual. Isn't that correct?
So the military personnel who are working in the labs are infectious disease specialists who do this.
I don't want to know who they are. I want to know, are they exposed?
They're considered actually low risk because they actually have the entire suite of protective equipment and the extensive training.
You know, one of my problems, General, very little time, and I want to be pleasant through this whole thing, but we have the head of CDC, supposed to be the expert, and he's made statements that simply aren't true. Doctor, you can get Ebola sitting next to someone on a bus if they, in fact, throw up on you, can't you? That's reasonable.
The way you get Ebola is by exposure to body fluids.
Okay.
Yes.
So when the head of the CDC says you can't get it with somebody on the bus next to you, that's just not true. When the head of the CDC says you cannot, in fact, that we know what we're doing, but in fact healthcare professionals wearing what they thought was appropriate protective material got it, then that means he's wrong. When the head of the CDC goes on television and says sometimes less protection is better, and then has to reverse the protocol so that we no longer have nurses, Ms. Berger, who have their necks exposed, that was just wrong, isn't it? Ms. Berger?
That their necks were exposed?
I mean, the fact is the head of the CDC gave false information, basically saying it was okay to have your neck area exposed, when in fact if somebody threw up on you, that could be the...
I honestly don't know that those nurses were instructed that their necks were okay to be exposed. I know that...
The head of the CDC, when asked about whether you had to have full body suits versus simply the mouth, said sometimes less is, more is not necessarily better. So the head of the CDC was wrong. We're relying on protocols coming from somebody who has been proven not to be correct. Isn't that true?
Those nurses were not protected, correct.
Okay. Mr. Roth, I don't want to belabor waste, fraud, and abuse at this hearing, even though that's a lot of what this committee looks for. But if I understand correctly, you have, your report shows that they didn't know what they were buying and why particularly well. They bought large amounts without a recognition that it was going to essentially expire, and without a plan to rotate it or in some other way put those materials into good use, the way DOD normally does in order to prevent items from expiring that have secondary use. Is that all correct?
That's correct.
And although I know you can't reach every conclusion, in your material, did you discover that, for example, the face masks, that instead of buying them, they simply could have had a rotating inventory that they could have drawn from that would have allowed the vendor to maintain a stockpile but rotate it so they would only take possession, which is also done at DOD on occasions. They would only take possession when they need it, and in fact, they wouldn't have to buy it, but rather rent the availability of it. Did you look into that at all, or did they look into that at all?
They did not look into that at all, and certainly when we make our recommendations, one of the things that we ask them to do is explore the types of options that you talk about.
So all of those options are going to need to be looked at, evaluated, and available to members of Congress before we start writing checks for large stockpiles. Wouldn't that be correct?
That's obviously up to Congress to decide, and certainly now the Department is starting to do the kinds of planning that we had recommended.
I'll close with Mr. Torbay. The pictures that the ranking member showed and the situation in Africa is certainly desperate, and I know my constituents are most worried about what comes here. But realizing that 4,000 there versus less than one handful here certainly shows us where the problem is, and I think you said that very well. But in fact, medical personnel that are dispatched from here go there and, in more than a few cases, find themselves infected. Isn't that true?
Correct. That is.
So I want to just ask, is that, it might be both, but is that primarily because of the conditions under which those doctors and nurses and other healthcare professionals find themselves working, or is it for lack of training? Is it more one or the other?
Mr. Chairman, it's a combination of both. Our medical staff, they're heroes, doctors and nurses. They work in probably 95-degree temperature wearing those PPEs that you've seen. Our rotations are every hour. We get them out every hour because they're dehydrated. So
they're capable of not getting infected if they were in a good facility dealing with one patient rather than questionable facilities endlessly for 24 hours a day trying to deal with an onslaught of patients. Is that correct?
I would say in our facility, it's a 70-bed facility. We have 230 staff members, and their only job is actually to look after the patients that are infected with Ebola.
Right. To the greatest extent possible, I'm going to ask one last question that I'd like to have people say a yes or no. Ebola is a 35-year-old disease. It is not new. It was discovered a long time ago, and we have spent money looking into it, planning for it. The various flus, the influenzas going back at least to 1918, are not new, and they have a similarity in that they can be transmitted and they kill. Since this is a 100-year-old process of dealing, at least, with modern infectious diseases, is there inherently a similarity in that, whether it's Ebola or, in fact, a pandemic, that we and Congress should be looking at the planning and the prevention and the training somewhat homogeneously? In other words, today we're looking at Ebola. Should we be looking at infectious diseases, the training, the prevention, the handling, the emergency? Should we on this side, the non-medical professionals, look at this as a failure of not just Ebola, but infectious diseases of this entire sort that we could have and should have been more prepared for? And to the extent you can, I'd appreciate a yes or no. Doctor? Or
yes.
Ms. Berger?
Yes.
Doctor?
I'd offer that it's a somewhat more complicated question. Ebola and flu are very different, and they are spread very differently.
Well, I was using infectious diseases and the isolation, the maintenance, and so on. I wasn't trying to say that those which can be aspirated or in some other way transmitted. The point, though, is AIDS and lots of other diseases, AIDS being much more similar to Ebola as far as fluid transmission, we have had these for a long time. We are now seeing failures. In your opinion, Doctor, are these failures to a certain extent the fact that we said we were planning to deal with infectious disease, prepare our healthcare system and our doctors and nurses, and in fact it appears as though we trained them but not trained them to the level we should. Yes or no?
No, I think that our failures largely relate to the fact that we're learning some new things about Ebola. Ebola's never been in this hemisphere before. And as we're learning those things, we're tightening up our policies and procedures as quickly as possible.
Mr. Roth.
To the extent that the viruses transmit in the same way, when we looked at the logistics, the acquisition management, I would say the answer would be yes.
Dr. or Mr. Lumpkin?
This is outside of our purview and lane.
Okay. So with that, I will go to the gentlelady from New York.
Thank you. And I first would like to thank all of our distinguished panelists for coming today during what is a critical time in the Federal Government's response to an urgent global crisis. First, I would like to take a moment to commend the healthcare professionals in New York City for their outstanding response yesterday to our first case of Ebola. New York City has been working with New York State, the Center for Disease Control, to prepare for this. And our nation's largest city, based on what we know now, I believe they have responded and done absolutely everything right. A young physician had returned from West Africa 10 days ago, where he had been working on the Ebola crisis with the Doctors Without Borders. Upon arrival into the United States, the doctor was flagged by the CDC and the Customs and Border Patrol and reported to New York City health authorities. Yesterday, when he reported that he had a 103-degree temperature and was experiencing pain and nausea, the New York City healthcare system sprang into action. The patient was immediately transported to a specially trained HAZTAC unit wearing personal protective equipment to Bellevue Hospital. The hospital had previously been designated for the isolation, identification, and treatment of potential Ebola patients by the city and state officials. Governor Cuomo has designated 8 special hospitals in New York City. Earlier this week, a specially trained CDC team visited Bellevue and determined that the hospital has been trained in proper protocols and is well prepared to treat patients. I must say that I respond to your concerns about nurses. And at the hospital, there were clear protocols in place established by the health department to ensure that nurses and all staff caring for the patient follow the strictest safety guidelines and protocols. Contact teams were ready to quickly identify, notify, and if necessary, quarantine any contacts the patient may have had on his 3 trips on a subway, visit to a restaurant, and a ride in a taxi cab. The health department is now working with the HHC leadership, Bellevue's clinical team, and the New York State Department of Health. And the CDC is assisting us daily in this effort. They are in close communications with the New York City Health Department, Bellevue Hospital, I would say all elected officials, and they are providing technical assistance and resources. The CDC already had a team of Ebola experts in New York City. They were already there to help. 3 members, I am told, were flown in last night from the CDC's so-called CERT team to join their colleagues already on the ground, and we are told that more CDC professionals will come in if needed. The CDC Ebola response team will arrive within 24 hours to any location in the United States where a case is reported. And so far, this is absolutely true. It's what's happened in New York City. This week, CDC named New York City and state as one of 6 states who will begin active post-arrival monitoring of travelers whose travel originates in either Liberia, Sierra Leone, or Guinea, and arrive at one of the 5 airports in the United States doing enhanced screening. Active post-arrival monitoring means that travelers without fever or symptoms consistent with the Ebola symptoms will be followed up daily by state and local health departments for 21 days from the date of their departure from West Africa. And active post-arrival monitoring will begin on Monday, October 27th. I want to reiterate that Ebola is not airborne. Someone infected with Ebola can only transmit the virus if they are experiencing symptoms, bodily fluids in direct contact, vomiting, blood, saliva, diarrhea. There are over 9,000 reported cases and over 4,000 deaths. I am told that the American health system is now actively reviewing 2 vaccines. They are in clinical trials, and we are responding. My question really is to you, Dr. Lurie, about the hospital preparedness program. But first, I would like to request that this statement that was prepared by the Trust for America's Health, a nonprofit.
Without objection, it will be placed in the record.
It talks about the need for enhanced funding, that our funding is not up to the threat that our country faces. I'd like to ask you, how does the program help to ensure that our hospitals that are so designated across America are prepared to respond in a health emergency? And I'd like to thank your program for the help that you gave to the great city of New York. Thank you.
The gentlelady's time has expired, but you, of course, can answer.
Good. Well, thank you so much. And we were very gratified last night to see the kudos to the program and kudos to New York City for their tremendous job in responding. Our program gives money to states, and in the case of New York City, directly to New York City to help the healthcare system become prepared. It is defined as a set of 8 basic things that every healthcare facility needs to do, and provides the funding for training, for exercising, for planning, for the purchase of personal protective equipment, and other things necessary for hospitals and other healthcare facilities to be prepared. It is, in fact, one of the reasons that Bellevue and I believe other hospitals in New York City have been able to do such a tremendous job getting ready for this, and we will continue to support them through this program and others as they move forward.
Thank you.
Thank you.
The gentleman from Florida, Mr. Micah.
Well, first I have to take sort of a point of personal privilege. The Chairman missed a word in his opening statement and apologized for being on a plane. The committee should know, the country faces 2 incredible threats right now. One is ISIS, or this threat we face from terrorists, and we've seen this week it threatens not only the United States but the world and our allies. But Mr. Issa and I accompanied him, and we had a Democrat member from the Foreign Relations Committee, was in Iraq. We were in Iraq last night. We left there at 6 o'clock in the evening and flew all night. And this is how dedicated he is to make sure that we're prepared over there, and you'd be so proud of our troops that we saw incredible, and General, too, you get called on to do some tough stuff, but I saw our men and women, and they're just awesome. And we had a chance to meet with some of our allies to get them to step up to the plate. But we face that threat nationally, domestically, and internationally. We face Ebola, a very serious threat. Dr. Torbay, this ain't going away anytime soon, is it?
We're hoping that we could contain it. If all steps that are being put in place are followed, it will be contained.
Here's a report I read on the plane last night. It says, experts warn the infection rate could reach 10,000 a week by early December. 10,000 a week. Is that semi-accurate?
That's what the report
the way things are going now. This is a report I got on probably the people that are most at risk are healthcare workers, whether they're there or here. Would that be correct? And this isn't up to date, but you had 404 cases of Ebola and healthcare workers. 232 died. Pretty high fatality, right, Doctor?
That's correct.
Okay. Thank you, Ms. Berger, for representing the nurses. Do we know how those nurses were, infected or exposed, how they caught Ebola, for sure?
Thanks to the whistleblowing efforts of Brianna Aguirre, we know that the nurses did not have optimal standards for personal protection.
Okay, so we know that they weren't properly protected.
Or trained.
Or trained, okay. All right, Dr. LURIE, you said that we're putting additional protocols in place, guidance, right? When was the most recent? A week ago, a month ago?
The most recent guidance on personal protective equipment has been in the last couple of days. It was
what about,
changed in response. It was changed in response to the situation at Dallas Presbyterian.
Okay. So in the last couple of days, what about, you said airport screening?
Airport screening.
When was that instituted, the new guidelines?
I can't recall exactly the date
a week
that it
ago.
started, but
Whatever.
the funneling into the 5 airports was in response in the last week.
Last week. I can tell you it's not working, okay? All you got to do is look at Craig Spencer. He was tested there. It's not working. Now, he is a medical professional. He reported himself. And then you see cases where, again, we are not prepared still. The whole part of this hearing is all about Mr. Roth's report. This is the Inspector General's report, right, Mr. Roth? And we spent millions of dollars getting prepared, right?
Correct.
Okay, and didn't you just testify that, in fact, and it's in this, I think, page 7 here, 200,000 of our pandemic respirators have gone beyond their 5-year manufacturer warranty?
The ones
is that right?
TSA, the ones that TSA
on page 6, don't you testify that this is a bottle of hand sanitizer, and you tested it. 84% of the hand sanitizer is expired that you tested. Is that right?
That's correct.
So how do I tell the American people that we're prepared, that we spent millions of dollars for a pandemic, and here it happens to be Ebola, and you just heard testimony how important it is to have the right protections. The equipment, almost all the equipment you cited in this report, in fact, is either out of date, the purchasing made no sense, we don't know the inventory, we don't know who's got it, and we don't know who's going to get it. Is that right, Dr. Roth?
Mr. Roth, but thank you for the promotion. Yes, you are correct.
The gentleman's time has expired, but if you call everyone doctor, you'll do very well.
Your report is correct, and I thank you. I have additional questions. Thank you.
Thank you. The gentleman from Massachusetts, Mr.
Thank you very much, Mr. Chairman. Thank the members of the panel for their testimony here today and for the work that they do on a regular basis. I think folks here that don't already know may be pleased to know that the news was just released that the Presbyterian Hospital nurse, Nita Pham, is Ebola-free, according to the National Institute of Health, and she'll be released today. So I think that's good news on one front on that. And I think also a little bit of good news, and Mr. Torbay was mentioning, is that the United States has taken the lead in the international response to this. And I think we don't often give credit where it's due on that, and I think we should all be proud that this country at least recognizes that not only do we have issues within our own country here that we have to deal with in terms of people that may be exposed or come down with the disease and come to this country or be here when they're treating somebody, but that you do have to go to the source with a shock and awe type of approach, as if you were in some sort of battle. We're losing lives and we're losing situations that could then endanger the entire international community. So we need a shock and awe. All the things that Mr. Torbay talked about. Do we have a large enough response? Is it coordinated accurately? Are the people that go there supplied and trained and equipped sufficiently to get the job done? So my first question might be to Mr. Lumpkin and Dr. LURIE and Mr. Torbay. Is the international effort now, in fact, large enough? Is it being well enough coordinated? Is there sufficient training and equipment for those that are involved in it? And if not, what remains to be done and by whom? So, Mr. Lumpkin.
In West Africa, U.S. leadership is galvanizing support on the international front. So what we have seen is that since we have gone in with speed and scale, that the international community is coalescing to come together in order to fight the Ebola epidemic.
Dr. LURIE, is that coordinated enough? Are the people well trained and equipped enough? Is the response sufficient enough, and who should be responsible for what remains to be done, if anything?
So I would agree with Mr. Lumpkin's assessment of the situation in West Africa. It has taken time to get the resources in place there. U.S. leadership has been incredibly welcome and incredibly important. As a result of that, we are finally seeing many other countries of the world step up to put resources in place in West Africa.
So, Mr. Torbay, maybe you can help me. Is the response adequate enough? Are people that are now involved trained enough and equipped enough? Is it well enough coordinated to be able to start containing this situation and then hopefully bringing it, wrestling it to the ground?
The U.S. and the U.K. have stepped up. Now it's time for the rest of the world to follow suit. The training is picking up. The DoD started their training. We started our training. The Ministry of Defense in the UK is starting their training in Sierra Leone. I think within the next 3 to 4 weeks, the training would be up to speed, which is critical. Supplies, PPEs are coming in. There are different levels of PPEs, but they're coming in. We hope that the pipeline will continue to come in. I think the other countries need to step up. We cannot forget about Guinea and containment of the Ebola in Guinea. This is where it started. Businesses need to get involved more. The economical toll of this outbreak is just phenomenal. We need to think about that. We need to think about technology as well. The development of vaccine is critical, but also technology companies need to start thinking about creative ways to monitor people when they're coming back, monitor their temperature instead of having to rely on patients checking their temperature twice a day. And I think if the interventions, the international interventions, continue at the same pace that it is now, I think it will be contained within the next 4 to 6 months. I would also like to thank the Department of Defense, the U.S. Navy, for putting a lab actually in Bong County, right next to our ETU. This has cut down the testing time from 3 to 5 days to 5 to 7 hours of Ebola patients. So we're accepting patients, testing them, releasing them if they're negative, and avoiding infection by them staying in the isolation ward.
Thank you. This isn't the hearing for it, but Mr. Roth, thank you for your work. I'm always amazed that agencies like DHS don't go to the General Accountability Office or somebody in advance to learn how to set up a protocol as opposed to waiting until they get audited later and find out that they didn't do it correctly. But, Mr. Chairman, I expect we'll hear that later. Dr. LURIE, last question. This is not a new, and Ebola has been around for a while. Obviously, people think that we could have been a lot further along in terms of vaccination or some other type of treatment or medicine on that, but there's been no profit motive sufficiently involved on that. What are we doing, not just with Ebola, but anything along this situation, in line with the Chairman's question earlier? What are we going to do to make sure that we have that kind of forward thinking, that if the free market and the profit motive isn't going to resolve these things and get them done, what are we going to be able to do as a public policy?
You know, I think it's a great question, and I thank you for it. Were it not for the investments in biodefense and getting going with Ebola vaccines and therapeutics, we would be nowhere near where we are now with the safety testing of 2 promising vaccine candidates going on and soon to be testing some therapeutics. So we do need to think about emerging diseases. We do need to think about developing products, countermeasures for them now. And we've appreciated the support from Congress for BARDA, the Biomedical Advanced Research and Development Authority, both through its direct funding and through the Project BioShield Special Reserve Fund, that have helped us ensure that there is a market, ensure that product developers and manufacturers will step up to the plate and work on these important threats.
So you're talking about public financing being used to establish those markets on that, as opposed to just the private industry on its own going out and trying to work with the free market aspect.
We've been talking about some very positive public-private partnerships and some tremendous models that we've developed over the past several years, whether it's been about biothreats or whether it's been about pandemic flu, and now with Ebola, that are really making that possible, yes.
Thank you. Thank you, Mr. Chairman.
Thank you. The gentleman from North Carolina, Mr. McCarroll.
Thank you, Mr. Chairman. My questions are for Assistant Secretary and the Assistant Secretary and for the General. We have our men and women in uniform that are now in regions that are severely affected by Ebola. To their parents, to their mothers and fathers of these men and women, do you have every confidence that they have every bit of the equipment and training that they need to be protected, to be safe, and to return home healthy? Mr. Lumpkin.
The safety of our service members.
The right answer is yes.
Is absolutely paramount, and while you can never mitigate risk to zero, I think we've taken all the steps to mitigate the risk, so my answer is yes.
General?
Sir, the combatant commander and the services are making every effort to ensure that the troops have the proper training and the proper equipment they need for this mission so that they can return home safely.
Mr. Lumpkin, you said in your opening statement that if infected, if someone contracts Ebola in country, they'll be returned back to the United States and cared for in a CDC facility. Is that correct?
I did not say that in my opening statement.
You mentioned a CDC facility where treatment will be given. Well, then let me ask a question. If somebody comes down ill in country, how will they be cared for? Will they be cared for in country, or will they be returned to the United States?
They will be returned to the United States, but I'll defer to my joint staff counterpart on the specifics.
Thank you for the question. So to take care of the troops in country, there will be 2 Role 2 hospitals, one established in Monrovia, one established in Sierra Leone. The medical personnel there will be trained in how to treat Ebola victims if a U.S. uniformed military person does in fact contract it. To ask your question whether they'll be treated in country or sent home, the answer is obviously both. If they are identified for some reason of having high risk of exposure, or if they actually do start to exhibit symptoms, they will be cared for initially in country, and then they will be moved home. If they're asymptomatic, they will do what we call a controlled movement, which will be an individual movement on a DoD aircraft.
Okay. How many aircraft are outfitted to move these individuals out of country in the event that this happens?
So for controlled movement, any aircraft can do, because they, as has been pointed out, they're asymptomatic and not contagious at that point, so any aircraft can do. At the present time, the only aircraft that can move the symptomatic patients is the State Department's Phoenix Air contract that you've seen moving the other Ebola.
And how many patients can that aircraft hold?
We're told, well, the aircraft can hold 1 at a time and can do 4 movements a week at this point.
4 movements a week?
Yes, sir.
Is that sufficient?
Given the number of Ebola patients that the United States has had in total at the present time, it is sufficient. However,
but that's not how these epidemics work.
Right. And so at this time, the Department of Defense has an urgent unstatement that's being worked through the system with Transcom to put together a isolation pod that can carry multiple persons, 4 C-17 aircraft. Testing will begin in October. Or I'm sorry, development will begin in October. Testing in December. Procurement will begin in January.
In January?
January.
In January. And how many individuals will be able to be transported?
15 at a time.
15 at a time. What's the turnaround time for the plane? How many movements a week can the plane?
I mean, we hope to procure a number of these systems so that they can be put on any C-17, so that if we we could move multiple C-17s to.
So at current state, we can take less than 10 people out of country in a week's time.
If they are symptomatic.
Yeah. So this is not at all sufficient.
We don't know if it's sufficient. At the current time, we will not be doing direct patient care, and so we anticipate.
I understand, but how many American troops will we have in the region by the end of the year? Well, what's our maximum?
In the vicinity of 3,000.
Of 3,000.
Yes, sir.
This is very disconcerting. Is it a question of, Mr. Lumpkin, is it a question of resources? Does Congress need to appropriate funds so that we can actually get more planes, more logistical support here so that we can have the capacity if something absolutely horrible happens to our fighting men and women in country?
Well, we clearly have an identified requirement, and as we develop the capacity, I'd like to take that one for the record, just to make sure I get you, because I'm not familiar with the acquisition of the process or the actual requirements that
well,
were
I think
historically
you
in
should
place.
get familiar with the acquisition process. If we currently have one plane that is controlled by the State Department, I'm asking the Department of Defense, with the mass number of airplanes, equipment, and training capacity that we have, spending nearly $500 billion annually on the Department of Defense. If you need it, we will get it. We will demand it, because if we're putting these men and women in harm's way, potentially where they can contract Ebola, the idea that we have one airplane as the United States to get these men and women out of country in a safe manner if they contract what is absolutely horrible, which we want to control, which we absolutely want to control. The idea that you're coming before us and giving this type of testimony raises great concerns. I know you've been asked to do a lot, and I absolutely respect that. But we're asking you in the legislative branch to tell us what you need, and we will get it, because we don't want to put our men and women in harm's way without any capacity to care for them. Our veterans, our fighting men and women deserve the best health care in the world, the best training in the world, and they have it. But it means the proper protocols at the top level are there to make sure they're protected, and if something bad happens, they're immediately taken out of harm's way, cared for, and returned back to their normal state. And with that, Mr. Chairman, I yield back.
I thank the gentleman. We now go to the second gentleman from Massachusetts, Mr. Lynch.
Thank you, Mr. Chairman, and I thank the ranking member, Mr. Cummings, for holding this hearing. And I thank the panel. You've been very helpful. As a matter of fact, there's been some marked contrast between some of the testimony here this morning, and I want to drill down on that a little bit, because sometimes that's helpful when people on the panel disagree. Dr. LURIE, you testified, and it's in your written testimony, that we are better prepared than ever, and that you have a comprehensive response on the ground. On the other hand, Mr. Roth, our Inspector General, you were commenting how the analysis done by, I think you were talking about DHS in your testimony, how the equipment purchases are not adequate, in some cases the wrong equipment, in other cases the usefulness of the equipment or drugs beyond the expiration date. Dr. LURIE, you testified that you have a very aggressive system in place, and on the other hand, President Berger from National Nurses United says that they've done a survey. They've done a survey of 3,000 nurses from every state in the Union and the District of Columbia, and 85% of those nurses say that they have not been trained to deal with Ebola, and that preparedness is, and this is a quote, woefully insufficient and dangerously inadequate. So those are two different stories of what's going on here. And now I understand we don't want to panic people, but we also don't need happy talk in terms of what we're dealing with. And maybe it's just me, but lately when a government agency comes before this committee especially and tells me there's nothing to worry about and we got this, that's when I start to worry. Now, as who to believe, I think the nurses, and I know I got some nurses here from the Massachusetts Nurses Association as well. I know how they work. They're on the ground. They are our front lines in this battle against Ebola. They are our ground troops. They are the people that are doing this work every day. They're exposing themselves and perhaps their families, if things go wrong, if they don't have the adequate equipment. So when they tell me that they're not prepared, I tend to believe them. I think those are facts. Those are facts. And we need to make sure that we get them the equipment and the training that need to protect themselves and to protect our communities and to protect their own families. There are a couple of facts that we've gotten in the briefings from the various panelists. One fact is that the CDC estimates that by this January, there will be up to 1.2 million people in West Africa afflicted with Ebola. 1.2 million. The estimate by DOD is 1.2 million. 1.2 million in January. Now, they were done at different times, so the difference might be just the period of time that they were taken. If things go as they are right now, 1.4 million. So we've got a real and present danger to the people of West Africa and to the people of the United States, who I'm pledged to protect. Now, I understand that the current approach is to use what they call a post-arrival approach, so that we're going to have these hospitals, and that as people arrive from West Africa, we're going to begin an analysis and a quarantine and checking them and making sure that they're not carrying Ebola. But it seems to me, and I listened, and Mr. Torbay, you've given some very powerful testimony, a lot of it written, quite frankly, and you haven't had a chance to talk about it. But you were saying that the focus should be on West Africa. And what we're setting up here right now with this post-arrival in the U.S. approach is we're going to set up these hospitals, all this equipment, everything here in the United States, and wait for those folks to arrive. And I believe that we should be doing just the opposite. Well, we should be doing that, but we should also be doing something else, and that is pre-departure. Pre-departure. We know that we're about to have 1.2, 1.4 million people in West Africa afflicted with Ebola. We ought to be on the ground there. We ought to have, instead of the restriction here in the United States after they come in of 21 days, there should be a 21-day pre-approval. When they say they want to travel to the United States, they need to present themselves and report in person 21 days before they get on that plane. And we can take their temperature and a blood sample if necessary, so that 21 days later, when they appear to travel, we can test them again. Now we've got 2 contact points on that person before they fly to the U.S., and we can also do that post-arrival check as well. But we are not taking this seriously enough. We are not. And, we need to help our brothers and sisters in West Africa, absolutely. But we've got to have a fact-based approach to this. This can't be just about ideology and happy talk. We have to look at this very seriously and have a scientific-based approach to what we're going to do about this problem. And I don't think it helps to say we've got an aggressive thing on the ground, everything's good, because I got a feeling in a couple of months you're going to come back here and give us a whole different story. We've heard that before. So we've got to approach this in a very deliberate manner and take it much more seriously than what I'm hearing here today. And we owe that to the citizens that we represent here in the United States, as well as to those individuals in West Africa who we obviously want to support as well. But Mr. Torbay, let me just ask a question wrapping up here. Your focus, you're saying that you want to make that containment effort in West Africa. Wouldn't it be, think about this, if we were putting our folks from all over the world, medical personnel on the ground, in Monrovia or at Freetown, wouldn't it be better? Wouldn't it strengthen the infrastructure there on the ground in West Africa as opposed to just having a post-arrival process here in the United States?
Thank you for your question, Mr. Lynch. As I mentioned, it needs to be contained at the source in West Africa. This is where the majority of the investment needs to take place. This is where training needs to take place. This is where equipment and supplies need to take place. And this is where most of the investment needs to take place. Now, that said, we cannot just focus on one without the other. What we're doing here in the U.S., we're treating with the symptoms of the outbreak in West Africa. We need to deal with the root cause of the outbreak, of the problem, and that is actually at the community level in West Africa. I believe pre-departure, there are some tests being taken, temperatures being taken for anybody actually departing any of those countries before they board the flight.
At the time of the flight, yeah, they get tested as they get on before they get on the plane.
correct.
But what I'm talking about is doing something 21 days before so that you've got 2 contact points that you can have measurements on. It's not foolproof, but having two contact points there in West Africa before you arrive here in the United States or elsewhere. Okay, Mr. Chairman. Thank you for your indulgence. I know I'm way over.
You have a quick response, Mr. Torbay?
One thing that we worry about in terms of 21 days, we're having difficulties recruiting health personnel from the U.S. to go and work there because the minimum requirement is 6 weeks. If we impose an additional 21 days, that's 9 weeks, and it's extremely difficult for any hospital or university to allow doctors or nurses to take off for 9 weeks before they come back. Again, we cannot completely wrap ourselves in a bubble here. Cases, people will go from Guinea or Sierra Leone to Senegal, will wait a week, take a flight to Europe, wait a couple of days, then come here, and there's not much we could stop it for doing that. So the preparedness needs to take place at both ends.
With all due respect, though, there's only a few flights. There's only a couple of flights out of there. You could actually do this.
We got to move on. I thank the gentleman for his good points. Dr. Lurie, when you were in front of Congress in 2011, back during the debate on the reauthorization of the Pandemic Act, the act that created your agency and your position, you had an exchange with Mr. Rogers, a colleague of ours from Michigan. He said this: there is a point person, somebody that makes the decision, somebody that is absolutely in charge. It's not CDC, it's not NIH, it's not FDA or anyone else. It's you. Your response was, that's right. So you're the key person, right?
My role is to be the principal advisor to the Secretary on these matters, yes.
You're the key person in the government for medical preparedness, public health emergencies. You're the key person in the United States government.
In HHS.
Got it. Let's go to the first slide if we could. I just want to put up a couple slides. This is straight from your website, just to be clear. It says, you are the person, your agency, the Assistant Secretary for Preparedness and Response, to lead the nation in preventing, preparing for, and responding to the adverse health effects of public health emergencies and disasters. Further down, the Secretary of HHS delegates to you the leadership role of all health, medical services support, function in health emergency and public health events. You're the key person. Correct?
That's what the legislation says, yes.
No, that's not the legislation. That's your website.
That is my role.
Yeah, that's your website. The legislation definitely says that. Your website confirms that.
Yes, that is my role. Yes.
You are the key person. Have you met with Ron Klain, the new Ebola response coordinator?
Yes, I met with him his first day, and I had several conversations and an in-person meeting with him yesterday.
Have you met with Tom Frieden, Dr. Frieden at the CDC?
I meet with and talk to Dr. Frieden almost every day.
Good. We would expect that to be taking place. Are you familiar with the story that Ms. Harrington did in the Washington Beacon, I think, story that says $39 million worth of NIH funding that could have gone to an Ebola vaccine? Are you familiar with that story?
I'm not familiar with the story, but if you familiarize me on the specifics, I'd be happy to respond.
I'm going to do that. Are you familiar with the fact that $275,000 on a restaurant intervention to develop new children's menu was spent of NIH dollars? You familiar with that? You familiar with the fact that $2 million were spent to encourage the elderly to join choirs? Money from NIH. You familiar with that?
I'm not familiar with the details of grant programs at NIH outside
$53,000 on a project studying size. You familiar with that? You familiar with the fact that $39 million of NIH funding was spent for all kinds of things that, I mean, I guess, cut to the chase. One of the things you learn in your first economics class, not that I was a great student, but I did study a little economics, and one of the things they tell you is that the term opportunity cost, right? When you spend and allocate resources for one thing, you by definition can't use those resources for something else. And so here's what I think a lot of American people want to know. Why, in fact, did we spend so much money on, for example, $374,000 to host fruit and vegetable puppet shows for preschoolers, when in fact some of this money, as cataloged by the press account and by staff, totaling $39 million, could have been used to help with treatment for something like Ebola and potentially a vaccine? Are you involved in the decisions that NIH makes when they're deciding how to allocate some of that money?
I'm involved in the decisions related to our biodefense and our preparedness programs for emerging infectious diseases. Yes, the NIH, the CDC, the FDA, my office, DOD, DHS, the VA, and the Department of Agriculture all work together on those issues.
But aren't you the point person in coordinating all that?
Yes.
So you're the point. So at some point you have to sign off and say it's okay that $374,000 is used for puppet shows instead of potentially being used, losing the opportunity to use that money to develop a vaccine to deal with something like Ebola.
So with respect, sir, I think you have, I'd like to do a little bit of clarification here. I think there's a little misunderstanding about how the NIH budget is allocated, but that's not my responsibility and my purview. So I suspect we should
well, let me go back to that same exchange you had with Congressman Rogers just a couple years ago when we were reauthorizing the act that created your position and made you the key person. Mr. Rogers says this. You said this when you responded to Mr. Rogers. How can we improve functions at the HHS to ensure that you are in fact in charge, that you're the person in charge? NIH is in HHS, right?
Yes.
Yeah. So you're the key person at HHS. How can we improve, Mr. Rogers asked you? You said, I have found through experience that indeed I have the authority that I need to be in charge. You follow up by saying, and I find that the collaboration with sister agencies and HHS, I don't think it has ever been better. We are working extremely close together. I think they recognize and respect the fact that we provide policy direction and are in charge. And I think all the efforts that we have undertaken to coordinate across HHS have done that. So you told Mr. Rogers when we were discussing whether we were going to reauthorize this act, keep your position, that in fact everything was working great. You were the person in charge. You were working within HHS, coordinating policy, direction, and you were in charge and working closely together.
And I would stand by that statement.
So back to the key question. Might we be a little closer to having a vaccine today if you weren't allowing all this millions of dollars, $39 million, to be spent on what many Americans view as questionable uses for their tax dollars, particularly in light of the fact we have an Ebola outbreak in the United States?
Thanks to the investments that we've had in biodefense and our focus and Department of Defense's focus on this critical issue over the past decade, we now have 2 vaccines in safety testing and at the NIH and Walter Reed.
Dr. Lurie, that's my point. Might they be further than safety testing if you hadn't wasted $39 million on a bunch of other things that most taxpayers think are ridiculous? In fact, one of your specific charges is in your, can we put up the second slide? Second slide specifically mentions, this is again from your web, Ebola. You're supposed to get ready for this. Might we be more ready if you hadn't spent $39 million of hard-earned taxpayer money on puppet shows for preschoolers and instead of invested that in treatment and vaccines for Ebola? It's a yes or no. You can. Yeah. Might we be further along if that money had not been spent someplace and could have been applied to the question at hand?
I don't believe that would be the case.
You don't think $39 million would have helped us get closer to a vaccine?
You know, the development of a vaccine is a long and complicated process. It takes
Is it a costly process too?
It is, and it
it's
takes
a costly
years
process?
and years and years to do
$39 million could have been used for it. You're the person in charge who works closely to direct policy direction. Those are your words, not mine. Might we have been better off if, in fact, it had been used to develop a vaccine?
I'm not in a position to comment on the overall NIH budget.
Gentleman is recognized.
I thank the Chair. I think the main public health message of this hearing is probably counterintuitive, that at least for U.S. citizens, we face probably more risk from the flu. So hopefully everyone will be getting their flu shot after hearing this hearing. There are many other public health precautions we could be taking, such as hand washing, things like that, which are too often neglected. Back to Ebola, the public is concerned that we're doing too little, too late. So I would like to explore some of the gating factors that might limit an appropriate response. Mr. Torbay was very specific in his testimony, mentioning that probably we're meeting, our manufacturers, there are only 2 apparently, are going to be able to meet only 35% of the estimated demand for the appropriate type of coverall. Could you name those 2 manufacturers? And we could perhaps explore what could be done to augment the supply of those essential coveralls.
First of all, I'd like to clarify that those manufacturers manufacture a specific type that we use. It's different than types other organizations use. And I do not remember the manufacturers, but I'll be more than happy to provide the committee in writing after the testimony.
For the record. There's some other gating factors. Of course, we all hope on the committee that we don't get to the point where we need augmented emergency flights by DOD to ship our soldiers back home. But Mr. McHenry asked an appropriate question, because our men and women in uniform and their families want to know that there will be sufficient capacity to get them back home. I think one of the concerns of the public is that 3 health workers have been infected in the U.S., and 1 actually overseas returning. And I think we're all looking for the right sort of response. This doctor in New York, we all hope and pray for his safe recovery. But when he felt sluggish on Tuesday, perhaps it would have been more appropriate to limit his contact with others, since he had been exposed to some of the worst of the infections in Africa. But that gap from Tuesday to Thursday, that will take an extraordinary taxpayer effort, contact tracing, all sorts of things, to try to limit the risk of exposure. What is the appropriate protocol for people who are known to be at risk during this crucial 10-day period, 11-day period, 21-day period, to try to limit contacts? Like everyone would have to feel sorry for his fiancée or his girlfriend or the other folks he was close to, when he's a skilled medical professional who presumably should have known, well, it's getting a little dicey here, and to call in when he has a 103-degree temperature. Is there a better response than that for any of the panelists? Ms. Berger.
I think it's unrealistic to expect that any healthcare professional that's working under extremely stressful situations, including Tina and Amber and several doctors, you have to remember that they're humans. You can't expect them to use their common sense at that point because they're patients. They need a team that they report to that checks on them, as Mr. Torbay has indicated, that follows them and makes the decisions for them so that they are no longer healthcare workers. They are patients that need our protection and care. And so to that end, it would make sense to have a professional team monitoring them and making the recommendations so they can actually relax and not have to worry that they're contaminating or exposing anyone unduly to the infectious disease. And I think that would really help in making sure that everybody that volunteers to take care of these patients and puts their own families' lives at risk actually is well taken care of after their service.
So you're suggesting that Dr. Spencer should have been viewed as a patient earlier than on Thursday and should have had a team of counselors to advise him because his judgment could not really be trusted at that point?
Exactly.
Well, that's a pretty bold recommendation. As far as international response is concerned, Mr. Torbay mentioned that U.S. and U.K. have stepped up. We've had some individuals in America, Paul Allen, Mark Zuckerberg, who've given more money individually than many nations have given. So that's an astonishing response, but what can we do to get more nations involved? I'm thinking, for example, of France that has had involvement in that area traditionally. What are these other nations? What should we expect of them?
I think an all-hands-on-deck approach is really necessary. I think a realization that this is, again, not a West African problem. It's a global problem that could hit any country anywhere around the world, especially with travel being the way it is. People need to realize the threat, and they need to realize that any contribution that they can make actually will make a difference. As you mentioned, private foundations and corporations here contributed more than some countries did. And I think the U.S. government should continue to put pressure on those countries to actually contribute to the cause.
Thank you, Mr. Chairman. I see that my time has expired.
I thank the gentleman. Now recognize the gentleman from Michigan, Mr. Walberg, for 5 minutes.
Thank you, Mr. Chairman. General, thank you for your service. Probably the #1 question or concern phone call I've been getting on this issue in the past several weeks comes from family members of our military, whether it be active National Guard, Reserve troops, a concern that what they've seen go on in places where they expect their family members to potentially have a death sentence as a result of being proud members of the military and signing on for that and committed to their efforts. Yet there are concerns that the way it's carried out at times, their loved ones haven't been given the necessary tools, armaments, rules of engagement, and all the rest to handle what they've been trained to do. That's a concern for them. But the biggest concern that they're conveying to me on those phone calls or meetings in public is that this is a potential death sentence being sent in to combat a virus, and with great uncertainty because of the multitude of changes in protocol, at least perceived by them, coming from what they hear in the news, hearing from leaders in this administration with responsibilities, and also the lack of information coming from the military on what they're doing. Let me ask if you would just briefly walk us through a daily routine of one of the soldiers that has been sent over to West Africa.
Congressman, thank you for the question. I've spoken to the commander on the ground, and I've talked to the folks at AFRICOM, and this question comes up quite a bit, actually. The protocols for an individual on the ground, for your average soldier, and again, I'd like to emphasize first, none of the military personnel will be providing direct patient care. We have 4 lines of effort: command and control, logistics, engineering, and training. So the protocols for treating patients is not something that individual soldiers will be doing.
But they do come in contact with contractors, with aid.
Absolutely. And so the protocols in place over there, as Mr. Lumpkin can testify to since he's recently returned, there's a no-touch policy over there. There's a 3-feet separation when you're talking to local nationals over there. And then that's being enforced both on the Liberian and the U.S. military side quite strictly. In your average day for a soldier over there would be obviously getting up, eating chow, doing the usual morning routine, get your temperature taken first thing in the morning, and then go out to whatever task you are going to do. Again, if you're in the command center, that involves going from your billeting directly over to the command center and sitting in a computer terminal or working on the generators or whatever it is that you're doing inside the command center. It involves eating only food from approved sources, drinking mostly bottled water or exclusively bottled water, and washing your hands in chlorine solution virtually everywhere you go. You go through your day. At the end of the day, every time you come back in the compound, at the end of the day, wherever you're living, you get your temperature taken again, more chlorine wash, in order to ensure that you stay Ebola-free.
Will the U.S. military personnel have ZMapp or any other experimental drugs available to them on the ground in Liberia?
There will not be any. I will have to take that for the record. I'm not aware that there will be any ZMapp available on the ground. The personal protective equipment will be issued to them depending on their level of expected exposure. For the vast majority of people, that will include surgical gloves, overgloves, boots, and a Tyvek suit. Obviously, for the medical personnel, it will be more along the lines that we've talked about here for the healthcare providers.
Dr. Lurie, in 2005, the Bush administration proposed a rule change that would allow the CDC broad powers to confine individuals that are believed to be infected with deadly pathogen like the pandemic flu. President Obama withdrew this rule in 2010. Do you believe the CDC needs or should have this authority to ensure an infectious disease outbreak like Ebola is contained and controlled?
Thank you for that question. You know, I think with every situation, we're always reviewing and taking a look at whether we have all the authorities we need to do the job. In our system of government right now, that authority rests with the states, and they have authority to do that when they think it's necessary.
But the CDC shouldn't have that authority that they did have, and it could be flexible There was certainly authorization. They didn't have to. Don't you think that would be a valuable authority to have?
So what I would say is I think that we are always learning and adjusting based on our experience, and that's one of the things I think we'll probably be looking at as we move forward.
Well, I hope so. We're sure learning right now. I'm not sure we're adjusting as rapidly as possible, and I'm certain we're not giving any type of security to our medical workers, nurses, including our citizens out there, that we have a solid policy in place that is first and foremost protecting our citizens against these type of problems. And I think it's evident by the hearing today and hearings that will go on that you're not bringing us a sense of security. And as a member of Congress representing a district, I'm expressing that point of view from my citizens who believe that we are less secure than we ought to be if we'd used the policies that had been put into place. Mr. Chairman, I yield back.
I thank the gentleman, and will now recognize the gentleman from Virginia, Mr. Conley, for 6 minutes in the spirit of equal time.
I thank the Chair. It seems to me that based on what we know and what we're hearing today in the panel, the United States objectives have to be twofold. Domestically, it is to protect and prevent. And that goal cannot be successful if we don't address the second goal, which is to deal with the disease at the source in West Africa. The two go hand in glove. And especially given the fact that we are potentially looking at an explosion of infection that is exponential in a very short period of time, next 2 months, it seems to me there is enormous urgency in the latter, not to diminish at all the need to address the former. Now, we had some good news today. A nurse, Ms. Pham, has been declared Ebola-free. Thank God. But as Ms. Berger points out, dealing with the first part, protect and prevent, it wasn't thanks to the protective gear and the protocols and the guidelines that were in place at her hospital. While CDC was giving us assurances how hard it was to contract the disease, we are pretty confident we've got things in place and so forth, 2 healthcare workers, including Ms. Pham, came down with it. Dr. LURIE, in retrospect, do you think perhaps, not intentionally of course, but in a zeal to reassure the public, CDC misstepped?
You know, I think that CDC has said that some missteps have been made, but they've taken a quick, hard look at the experience. They've pivoted, as you see.
Dr. LURIE, I am asking a public information, public health question. I've had to deal with that in my county when I was the head of my county during anthrax attacks. And one rule I had was never reassure the public when you don't know. Never do that, because when you do that, you damage your credibility. And you heard it here today from some of the questioning on the other side of the aisle. Gave them an opening to attack the credibility of the administration by extension, because the CDC was not capable of saying, not yet, we don't know. We're still, it's a work in progress. What's so horrible about doing that?
I think you're right now, is if we look at the situation, we see that it is a work in progress, and what you see is that we're taking constant steps to adjust as we learn more.
Ms. Berger, you indicated that you would welcome a law establishing, if not an executive order, but preferably a law because that codifies it, establishing uniform guidelines, uniform protocols, so we don't have this up and down myriad of procedures at hospitals depending on where you live. Is that correct?
You left out one, excuse me, you left out one critical word, which is mandatory optimal standards for personal protection.
Yes.
The CDC guidelines are merely guidelines, and all 5,000 hospitals in the USA get to pick and choose what part of the guidelines they implement and the personal protection.
I take your point. Dr. LURIE, would the administration welcome such legislation, and or is the President contemplating such executive action?
So one of the things I think to keep in mind is that the federal government does not license or regulate hospitals in this way. Hospitals are licensed and regulated primarily by the states, but I think it's fair to say at this point that no hospital wants to see its healthcare workers infected. The CDC guidelines now provide a couple of options for safe personal protective equipment in large part because there's probably not a one-size-fits-all solution. It's important for people to be able to practice in the equipment that they are using and comfortable using day to day, provided that it meets the safety standards that CDC has articulated.
Okay. Not sure what that means in terms of whether the administration is contemplating an executive order or whether you would welcome some legislation that would make it mandatory, as Ms. Berger suggests, but we'll be in touch, I'm sure. Final set of questions, Mr. Torbay. In the United States, there are 245 doctors per 100,000 population. In Liberia, 1.4. In Guinea, 10. Sierra Leone, 2.2. Health spending per capita, $8,895 here in the United States, $65 in Liberia, $32 in Guinea. CDC says if we don't achieve 70% of isolation of existing Ebola victims in the affected countries, the number of victims or people with Ebola in these areas could reach 1.4 million by January 20th, the day roughly around when the President gives his State of the Union address. That is astounding, and whatever problems we've got with the relatively limited number of Ebola patients in the affected regions obviously becomes enormously magnified when you're looking at that kind of number. How in the world do we contain this before it becomes explosive? It's already the largest Ebola epidemic ever recorded, but to go from roughly 10,000 or so to 1.4 million in the next 2.5 months is it's jaw-dropping.
Thank you for your question. There are steps that could be taken and that are being taken to contain this and to hopefully never achieve that 1.4 million number. And that includes isolation of patients, quick isolation of patients the minute we know that they develop symptoms, treatment, referral to the Ebola treatment units such as the one that International Medical Corps is running in Bong County.
And if I could interrupt you, and Mr. Chairman, I promise this, I'm done after Mr. Torbay. CDC says if you isolate 70% now, you achieve complete abatement of Ebola in the affected regions. I mean, in other words, then we're on a path to the complete reversal of the progress of the disease. But if we don't do that, we're headed in the opposite direction. Sorry.
In addition to treatment, community awareness and education is critical. But also, we cannot forget the need for regional preparedness outside of those 3 countries. We know of one patient in Mali already yesterday. A 2-year-old girl was taken into a hospital in Mali. Regional preparedness is critical, and that includes training of teams that could actually treat Ebola, detect burial teams, contact tracing. It includes consistent community messaging, so there are no 2 conflicting messages that go out, as well as stocking of supplies that are needed in case of an outbreak. This is critical as well, and this is an area that's being ignored in terms of preparedness.
Thank you. And Mr. Chairman, thank you for your generousness.
I thank the gentleman. Now recognize the gentleman from South Carolina, Mr. Gowdy.
Thank you, Mr. Chairman. I want to start, Mr. Chairman, by thanking nurses and doctors, hospital workers, soldiers, and others for their courage and their service and their sacrifice. Most of us, Mr. Chairman, in life run away from danger and disease and risk, and very few people are willing to run toward it. So I want to start by thanking that group of people. Dr. LURIE, I want to read you a quote and you tell me if you can tell me who the author of this quote is. Beginning with the development of a strategy, my role can be defined as helping our country to be ready for any kind of adverse public health event, including a response to any challenges the future may bring. Do you know who said that? Who? You did. That's exactly right. In Penn Medicine article. And your bio page says that you are the Secretary for Preparedness and Response, and your work has included evaluating public health preparedness, conducting 32 tabletop exercises on hypothetical crises such as smallpox, anthrax, botulism, plague, pandemic influenza. Another story on you and your career, which is an incredibly commendable career, said your job is to plan for the unthinkable. A global flu pandemic, she has a plan. A bioterror attack, she's on it. Massive earthquake, yep, she's got a plan. It's a mission that includes both science and a communication strategy. So I was sitting there, Dr. Lurie, thinking, here we have a doctor with an incredible background in medicine who also happens to have planned for crises like Ebola, whose job description also includes communication strategy. So why in the hell did the President pick a lawyer to be the Ebola czar and not you?
So I appreciate your questions. Before I answer your question, can I take just one moment to clarify my answer about the quarantine question, because I think I didn't understand it fully. CDC has ample quarantine authority to do what it needs to do. I think and it's used those authorities many, many times. The proposed regulation would have refined the process we have used, but the underlying statute already gives CDC the authority that it's needed. Okay. So with that clarification, I just wanted to—
The record is now complete with respect to your position on quarantine. Okay. Now, I want the record to be complete on why in the world the President picked a dadgum lawyer to head the Ebola crisis instead of somebody with your vast and varied background.
And I appreciate the vote of confidence. The role of the Ebola coordinator in the White House is a whole-of-government coordination role.
Well, I appreciate that, Dr. Lurie, but Mr. Klain is not a doctor. He's not an osteopath. He's not a nurse. He's not an epidemiologist. He doesn't have a background in communicable disease. He doesn't have a background in infectious disease. He doesn't have a background in West Africa. So how in the world is he the best person to be the Ebola czar and not you? And I don't want to hurt her career. I do not want to hurt Secretary Burwell's career, and I fear that I will by complimenting her. But she's an incredibly bright person. One of the more capable people I have met in the last 10 years is your boss, the Secretary of HHS. Now, we disagree, in fairness to her, on lots of policy. But she actually has a background through her work, the Gates Foundation, in global health. You're a doctor. I mean, if this were an outbreak of people who don't have wills in West Africa, or if this were an outbreak on contested elections in West Africa, then I'd say, yeah, go hire Mr. Klain. But it's not. It's a medical crisis. So why not you?
So right now, I have a full-time job doing my job in the Department of Health and Human Services. I really appreciate the vote of confidence, and I have a lot of confidence in Mr. Klain.
Well, how about another doctor? How about somebody who's an expert in infectious disease, or an expert in West Africa, or the delivery of health care? I mean, God forbid we pick somebody with a background in medicine instead of a dadgum lawyer. And in the interest of full disclosure, I am one.
So with respect, I think that the role of the coordinator at the White House doesn't require a doctor. It requires somebody who is really expert at coordination and bringing the parts of government together to enhance the coordination.
Well, I'm going to make you this promise, okay? And I want you to hold me to it, okay? The next time there's an opening on the Supreme Court, I want you to see whether or not the President considers a doctor or a dentist for that job. And we actually are about to have a vacancy for our Attorney General. And I want you to consider or be mindful of whether or not he considers maybe like a tattoo artist to be our next Attorney General. I promise he will not. He will pick a lawyer for the Supreme Court, and he will pick a lawyer to be the head of the Attorney General of the Department of Justice. I'm just lost as to why he wouldn't pick somebody with a medical or health care background to be the Ebola czar. I mean, can you understand why people might possibly think this could perhaps be a political pick instead of a medical science health pick? Can you understand how people might be just a little bit suspicious?
I can understand the public's concerns about a whole variety of issues. I believe that Mr. Klain has tremendous experience in doing the job that
Well,
he has
cite me
chosen to
all
do.
his medical background then. I was going to let you go, but you said he has tremendous experience. Cite me all of his medical, infectious disease, communicable disease, healthcare delivery background.
You know, one of the terrific things about the way the government works together is that experts come together all the time.
I'm going to take that answer as a he has none.
There are a tremendous number of doctors that he has at his disposal. He has me, he has Dr. Frieden, he has Dr. Fauci, he has Dr. Collins. You could go on and on and on.
Yeah, and it would just make, but you know what? We had access to all those people before we had Mr. Klain. All those people worked for the government before the President hired Mr. Klain, didn't they? So why pick a lawyer to head our response to Ebola? It just, you know, color me cynical, it just appears to be political. But with that, Mr. Chairman, I would yield back.
Would my friend yield?
Of course I will yield to the gentleman from Virginia.
Well, I just wanted to join my friend in calling for a non-lawyer appointment to the Supreme Court. It would be the healthiest damn thing we've had in the last 50 years. Thank you.
Are you applying? Are you interested?
Thank the gentleman. Now recognize the gentlewoman from Illinois, Ms. Kelly, for 5 minutes.
Mr. Chair, Dr. LURIE, are you trying to say that we need someone good at coordinating and managing and really cutting through a lot of the BS?
That's exactly right.
Thank you. I want to thank the panel for meeting with our committee today to discuss this important health crisis issue. And I want to let you know that my thoughts and deep appreciation are with all the healthcare professionals dealing with this crisis, and those in the audience, and because I represent Illinois, a special shout out to those from Chicago, the Chicagoland area. My questions are about the DOD's role in West Africa. Secretary Lumpkin, I know there are some that have commented that there is no reason to involve the U.S. military in this type of humanitarian crisis. Why is the U.S. military so critical to getting the epidemic under control in West Africa?
Thank you for the question. Again, we are in direct support of USAID and their whole-of-government efforts. USAID came to us because of our speed and our scale with response. We can mobilize quickly. We can instill command and control, provide the infrastructure. We have the ability to do logistics. We do it very well, both strategically and tactically, to move supplies. The one thing you have to keep in mind within Liberia, they get about 200 inches of rain a year. When we were there, it was raining, 6 to 8 hours a day some days. In that time, many of the roads are impassable except by foot, and what goes with by foot is the Ebola virus as well. So there was inaccessibility to the various areas. We have the ability to reach and get those areas and to support USAID. We have the ability to do construction and to build these Ebola treatment units. When I was there, I had a chance to get on the ground and talk to some U.S. Navy Seabees who were building the Monrovia Medical Unit. And working through the rain, with the equipment there to get what looks to be impossible, they make possible. Then the final piece is we can do scaled training. We can bring a boot camp-like training to train up to 500 healthcare workers per week to man and to staff these Ebola treatment units. And so we bring the capacity in order to do that. So again, we are an interim solution as we roll in there to support USAID until the international community can mobilize in order to take over our efforts.
So you feel you have extensive experience in conducting humanitarian efforts like this?
Well, we have supported USAID on numerous occasions. We did it in Haiti. We've done it in places, Japan just several years ago, the Philippines most recently. The team on the ground we've worked with before, the team lead has from the Disaster Assistance Response Team, has extensive experience working with the Department of Defense. And we're very tightly lashed up, and I would say it's seamless.
Okay, thank you. General, can you provide us with a status update on the operations in the region and let us know what your biggest challenges are?
Yes, ma'am. Thank you for the question. As Mr. Lumpkin said, we were asked to do this mission because of our unique capabilities. as we are here today, we have 698 personnel on the deck, split between Liberia and Senegal. We're expecting here in the next 24 hours, 101st Airborne Division will complete its movement in the country, and we will begin a rotation for them to take over the command and control piece of this. Equipment continues to flow through our intermediate staging base in Dakar, Senegal. As Mr. Lumpkin said, we were asked to do engineering. USAID asked us to be prepared to build up to 17 Ebola treatment units. We've actually been asked to build 12, and 3 are currently under construction. And as for the training effort, we have identified the Painesville National Training Center in Monrovia as the site where we will bring in military trainers to begin training healthcare workers here in the next couple of weeks.
For both of you, if this epidemic is not contained and it spreads further over the continent, do you agree that this really affects international security?
Again, to reiterate my opening comments, this is a national security priority for the United States that truly has global impacts. So we have an opportunity right now to flood the zone, to make sure we have the capabilities in country, working as a whole of government, and mobilize the international community to respond while it still is at a point, while dire. If it gets worse, it's going to be harder to manage. So we need to take this opportunity we have right now.
General, did you have anything?
Nothing additional, Admin.
Well, I want to thank you both for your testimony and for your service to this country, and again, a deep appreciation to all the healthcare professionals. Thank you.
Thank the gentlewoman. Thank the gentlewoman. I'll now recognize myself for 5 minutes, and I want to thank the 6 of you for your dedication and commitment to fighting this, and for the efforts here in the United States of America. And to the men and women who serve on the front lines, those healthcare workers and first responders, I joined Mr. Gowdy in thanking those that will actually run to the sound of the guns in the crisis that happened. They're amazing individuals, and they have our thoughts and our prayers and our hearts behind them. I have a few questions, particularly on the military side of things. I don't know whether to start with Mr. Lumpkin or the General, but help me understand their proximity to the challenge here. How many USAID personnel are they supporting?
I don't have that number off the top of my head, and I want to be accurate, so I'd like to take
Do you have a range? I mean, is it hundreds? Is it?
It's so integrated. The disaster.
Okay. If you'll get back to me, our time's short.
I'll be happy to do that.
If you'll be happy. My understanding, Doctor, we got one doctor here on the panel, is that there is a 21-day window in which a person who may have been exposed to Ebola will actually potentially come down with Ebola and start to show signs of having this virus. Is that correct, 21 days?
That is correct.
So, General, why do we only hold our troops for 10 days before we release them to bring them back to the United States?
Yes, sir. Thanks for the question, and I can understand the confusion on this, but let me see if I can make it clear. To start, the 21-day period for monitoring has to take place outside the infection zone. For us, that'll be in the United States. Out of an abundance of caution, prior to departure, in order to reduce their risk, commanders will be allowed to remove their personnel from whatever jobs they were doing for up to 10 days prior to departure from Liberia, in case just to limit their exposure and provide an extra layer of protection. However,
I'm going to need further explanation of this, because I don't understand the 10 days when the science says the 21 days. But
the 21 days takes place, the 21-day monitoring for U.S. military personnel will take place stateside after they've left in order to ensure that they are Ebola-free, just as was described previously for other healthcare workers.
Let me understand, Doctor. The written materials that I do see out there talk about fever, which is monitored twice a day in the case of the military, and other symptoms. What are the other symptoms?
Other symptoms might include nausea, diarrhea, red eyes, muscle aches, fatigue.
So any one of those symptoms could be happening and not have a fever, and you could have the Ebola virus, correct? You could have fatigue, for instance, before you have a fever.
That is correct, but you really only transmit the disease when you are febrile.
So if you have one of these symptoms, and you're coming through Customs and Border Patrol, for instance, is one of my deep concerns. We got about 1 million people a day that come through the United States border. We got these Customs and Border Patrol agents and officers that they're wonderful people. I mean, they are as dedicated and committed. It's a tough and difficult job, and we're asking them to make an assessment of somebody in about a minute or so as to whether or not this person potentially has Ebola. How in the world are we going to train them so that they can have these assessments?
So let's be clear about what's happening now. First, all travelers are funneled from West Africa are funneled to 5 major airports where people are specially trained to do Titan screening. If, in fact, they have symptoms of Ebola or they have a fever, then they get referred to secondary screening, and then, additionally, they are interviewed by staff.
Are you telling me that it worked? Did it work in the case of Dr. Spencer? Did it work?
So the reason that we now have moved to active monitoring of all people that come back from these countries to the United States is exactly for this reason. So that if people don't have a fever...
You see where we lack some confidence, right?
If the people don't have a fever when they come through the CBP, Customs and Border Patrol stations, we still believe they need to be very actively monitored for 21 days. That's exactly what happened.
But
Dr. Spencer took his temperature at the earliest moment, as I understand it. He called authorities and was isolated very expeditiously.
So you don't think he was contagious those 48 hours before?
From what we understand, people are infectious when they have a fever, not beforehand.
So why did you close the bowling alley? Why did they put other people in quarantine? If he's not contagious because he showed a fever and he's a doctor and he says he didn't have a fever until that morning, why did you have to shut down the bowling alley?
You know, it's a good question, and I think it gets to your issue of confidence. We really want to move in an abundance of caution. The bowling alley is closed so that it can be cleaned and decontaminated out of abundance of caution, and I expect it will be open and people will be bowling in the not-too-distant future.
You could have gotten sweaty, right? And you can transfer this via sweat, right? For that secretion could actually hold the Ebola virus for some time, correct?
So the bowling alley is being cleaned out of an abundance of caution, yes.
I just don't have the confidence that we're dealing with people who have a known, we're talking about people who come in direct contact with Ebola patients, why we wouldn't hold them for a 21-day period to make sure that their loved ones, themselves, the people of this country, I don't understand why we wouldn't put that travel restriction in place, why we don't get a little bit more strict in putting quarantine. The self-quarantine didn't work. It didn't work in the case of Dr. Spencer, and he's one of the great people of this earth. I mean, he went to go help save people's lives. And he's an emergency room physician, my understanding. So that's the concern.
Will the gentleman yield?
Sure.
Thank you. I would like a clarification from the Major on one of your responses to the Chairman's questions. You said that the quarantine cannot happen in the country of origin or the country of infection, and that you would quarantine him, as I understand from your answer, 10 days in, say, Liberia before you would allow them to come to the United States. My first question is, why can't you quarantine?
We don't have first questions. Ask the question.
Clarification.
We have to yield the people with flights. Yes.
Clarification. Why can't you quarantine in the country of infection, particularly if we're sending over military that could build a quarantine unit?
Ma'am, I'll defer to the doctors, but what our infectious disease personnel tell us, in order to be absolutely certain that everybody is Ebola-free, it has to be outside the infection zone, and for all intents and purposes, the entire country of Liberia is an infection zone. But I would defer to the doctor for clarification.
Go ahead.
So the CDC's guidelines right now indicate that if you have no risk if you've not been exposed to other people, you haven't touched other people, you haven't been caring
her question was about military personnel who were in the infection zone who did have contact.
You haven't cared for sick Ebola patients, and if you're in personal protective equipment, you haven't had a breach of personal protective. You haven't had a breach of your personal protective equipment. That, depending on the category, you are at low or no risk.
I'm not buying it. I'm just not buying it. My time has expired.
Yeah. Okay.
We'll go to the gentleman from Pennsylvania, Mr. Cartwright, for 5 minutes.
Thank you, Mr. Chairman. I want to follow up on that. Thank you for joining us today, Secretary Lumpkin and Major General LARIVIERE. But, you know, the expression an abundance of caution has been used here in this room today. And what I'm wondering specifically, and I'll open that up to either of you gentlemen, is there any reason why this proposal, you know, Mr. Lynch brought it up, Mr. Connolly brought it up, Mrs. Maloney brought it up, I believe Mr. Chaffetz brought it up. Is there any reason why we wouldn't just want to use a 21-day waiting period in West Africa before we bring people back to the United States?
Our 21-day monitoring process is done at the unit. It's done twice a day as far as whether they'll have direct contact with a healthcare professional for everybody who comes home. And it is commensurate with guidelines that other organizations are following. So we are following the same guidelines as that CDC and others recommend.
When you say in the unit, you mean in the unit, whether it's in West Africa or in the United States?
No. When they return, well, there's in-country monitoring, and there's monitoring once they return home. Okay. So once they return back to the continental United States or their port of origin, so to speak, is they will go through a 21-day process where twice a day, 12 hours apart, they will report to their unit and do positive discussion with the healthcare provider and have their temperature taken to see if to make sure that they don't become febrile or show any symptoms. But keep in mind, going back to the risk of the Department of Defense personnel in country is because we are not providing direct health care to Ebola patients, our risk is much, much lower than those that do, to begin with.
All right. And you're answering my question with what we're doing, and I'm asking you, why couldn't you do it a little differently? Why couldn't you do the 21-day waiting period in country, just to be extra careful that we're not bringing this virus back to the United States?
Yes, sir. Again, everybody in country will be monitored twice a day for their temperature. So for all intents and purposes, we're basically doing what the CDC recommends every single day while we're in country by having their temperature taken twice a day. Immediately prior to departure, we will have personnel, we'll go through a questionnaire to find out if in the last few days, right before they left, if they have been in more, possibly could have come into contact and be anything other than a low-risk category before we transport them home to start the 21 days in CONUS. The 10-day period, which is causing all the confusion, was merely an additional period in which case they would be removed from whatever jobs they were doing if they were out and about the town in order to further reduce their possible risk.
Well, General, I thank you for that answer, but again, you're telling me what the plan is right now, and I'm asking you, why couldn't you be a little more careful with the plan, go a little more overboard with the protection, and extend the in-country waiting period to 21 days rather than the 10 days? And it seems to me that you gentlemen are deferring to the CDC on this, are you?
Well, sir, it's the CDC. It's also the U.S. military infectious disease doctors who, in consultation with their interagency partners, are the ones that—
Well, let me cut it short then. May I ask you, gentlemen, to please consult with those sources and ask them to consider a 21-day in-country waiting period just to be in a real abundance of caution.
We will do that.
I thank you for that. I also wanted to ask, you know, we've heard about this terrible potential for the spread of this disease in West Africa. What did we say? By January, a million infections or more? The suffering, the horror there. One question I have is, number one, is 3,200 American servicemen and women enough to properly train to defeat this Ebola enemy?
Based on the requirements that have been asked of us from USAID, who we're supporting in country, the answer is yes.
And then the next question is, are there enough trainees? Are there enough healthcare workers in West Africa that we can train enough people to take care of the problem?
That is a question I would have to defer to the USAID and their expertise on the ground.
Anyone on the panel like to take that question?
There are health workers, not necessarily from Sierra Leone and Liberia, from the U.S., from other African countries, from Asia, that we're bringing to the country as well to help with the treatment and the containment. And we're hoping with the training that's being provided and the supplies and the momentum that's actually now ongoing, that should be sufficient. That being said, for the time being, it's still really difficult to encourage people to go and work in West Africa, given the conditions on the ground, but also given the conditions that they might actually stay in West Africa for a longer period as well. So this is why we're trying to